สวัสดีค่ะยินดีต้อนรับนะคะกลับเข้าสู่ IAOC Series นะคะซึ่งครั้งนี้เป็นเรื่องในเรื่องของ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice นะคะแล้วก็เช่นเคยนะคะเราได้รับเกียรติจาก Expert จาก IAEA นะคะดร Sam Brady จาก Cincinnati Children's Hospital นะคะซึ่งครั้งนี้เนี่ยก็คือเป็นอาทิตย์ที่10ละเรามีทั้งหมด12ครั้งเรามาเกือบจบแล้วนะคะครั้งนี้เป็นครั้งที่10แล้วอาทิตย์นี้เนี่ยเราจะมาพูดถึงในเรื่องของ Imaging Quality Metric ของ Mammogram นะคะแต่หลังจากที่อาทิตย์ที่แล้วเนี่ยเราส่งคำถามไปให้คุณแซมนะคะว่าเรามีคำถามเกี่ยวกับเรื่องของการ shielding ใน radiology เนี่ยว่าส่วนไหนต้องชิลส่วนไหนไม่ต้องชิลหรือเดี๋ยวนี้เราไม่ต้องชิลแล้วเนื่องจากไกด์ไลน์ใหม่ที่ออกมานะคะซึ่งคุณแซมก็ใจดีมากนะคะที่จะเลคเชอร์ให้เราฟัง1ชั่วโมงเลยนะคะ1เซสชันในเรื่องของเรื่อง shielding ทั้งหมดของ radiology นะคะก็ Good evening, Sam. Welcome back again on the IAEA Expert Mission. And this week is week 10 that we're supposed to talk about the mammogram stuff. But after last week, I have a questions for you about the shielding in radiology. Do we still need to do shielding in CT, like a gonad shielding, thyroid shield, or breast shield, or something? So the plan is you are going to give us a talk about the shielding, every shielding in radiology, what should we do or do not do, and the basic principle and concept on that things. And the next hour, we are going to talk about the mammogram, like image quality, metrics, and also optimization. So welcome back again. Yeah, let me unmute you. Hold on.
Thank you. I couldn't unmute myself.
Okay.
You didn't want me to talk, did you? Well, thank you, Tanya. Thank you for the introduction. Once again, I'm glad to be back for everyone that's here with us live. And yes, just like Tanya mentioned, at the very end of last week, there was the question about patient shielding. So, of course, last week, I guess for the last 2 weeks, we've been talking radiography. We've been talking generally DR and CR imaging. And so the question came up, what about shielding, patient shielding? So there's a lot of different ways we shield our patients. And I wanted to talk a little bit about that. So I'm going to answer the question that Tanya asked about gonadal shielding. But when I started putting this talk together, I also decided, gonadal shielding is very specific, of course, to DRCR, but what about shielding that we use in dental and mammography and CT? And so I've decided to create one lecture based specifically on answering the question, what should we do about shielding? And we'll go through all of the modalities and all of the different ways that you can shield in each of these modalities. So it's going to be a very complete discussion. Hopefully we'll have lots of good questions and we can have a good conversation at the end. So I'm going to talk to you, I'm going to show you the science behind the use of these shields. So I'm talking about patient shielding. I just want to stress that a couple of times. I'm not talking about staff shielding. So people that work in fluoroscopy, you put your aprons on, your thyroid shields, you might even wear your glasses. I'm not talking about that. That's stuff that is really good. That's very important for you as a staff member. So this is about a patient that comes in and do we put shielding on them when we're doing imaging? And then, like I said, I definitely will, I promise, I am going to talk about gonadal shielding. So before we start, I'm going to jump to the end. I'm going to give you the conclusion. I'm going to give you 2 statements. And then I'm going to spend the rest of the hour trying to justify these 2 statements. The first statement is, generally speaking, patient shielding is ineffective and unnecessary. And the second statement I'm going to make is, once again, generally speaking, when patient shields do not affect image quality, they can be used to help patients. Oftentimes, we use them when a patient's nervous about radiation or when they request personal shielding. There's nothing wrong with it as long as it doesn't interfere with the imaging. And in pediatrics, actually putting a heavy lead apron on them will actually hold them still and they won't move as much. So there are some positives to it. But for using aprons, these lead aprons, for shielding purposes, I hope to demonstrate to you why they're not that necessary anymore. So there are always exceptions to every rule, and I hope to demonstrate those as we go through. So you may already be thinking in the back of your mind, thinking, wait a minute, I've seen this be very helpful. And so we'll talk about that when we get to those examples. So because this was the original question, I'm going to start with gonadal shielding. So let's give a little bit of perspective. When did gonadal shielding, when was it first introduced? So in the US, unfortunately, I don't know the Thai history, but in the US, gonadal shielding began to be used in the 1950s. The main purpose, the whole reason that they started placing lead shields on top of the gonads for people when they were receiving an x-ray was to prevent heritable genetic effects from radiation exposure. The concern was that if exposing the gonads, there would be some kind of mutagenic effect, and then that would be passed on through the reproductive process to the progeny. And so we didn't want to affect the gonads, and thus, of course, the gametes, the sperm and the egg, so that we would have issues, genetic issues in our offspring. That was the purpose, that was the thought process behind using gonadal shielding back in the 1950s. You have to understand, though, putting this all into context, back in the 1950s, this was only a couple years after the atomic bombs were released in Japan. And so our understanding of radiation effects and risk was primarily, of course, from the Hiroshima and Nagasaki bombs, but they were based on deterministic effects. A couple of years, about 5 years out from the dropping of these two atomic weapons, we didn't have a lot of data to start projecting future cancers. But we definitely saw skin burns. We saw a lot of those types of effects. And so we immediately from the beginning knew that radiation would damage the body. We just didn't know to what extent it would be long lasting, or it could be passed on through the reproductive process. As I mentioned, our understanding of stochastic effects or cancer was very, very early, very nascent at that time. So also, looking at this historically, what were the radiation doses? What was the level of radiation we used in planar radiography back in the 1950s? So for an adult anterior-posterior radiograph of the abdomen, just a single view, they were about 11.5 milligray. Now, if you did an AP of the pelvis, it was about 9.5. If it was a kid, of course, it was smaller because the patient was smaller, but it was about 1.4 milligray. So fast forward to more recent studies. So a study that came out of Europe, their value was 0.8 milligray for an AP radiograph of the abdomen of an adult. So substantial reduction, almost over a tenfold reduction in radiation dose from the 1950s to now for the exact same view of the exact same abdomen. And then if you look at the Thai data that we had looked at from the very beginning, the data that you guys have collected, you guys are about 2.8 milligray for an AP abdomen, an adult AP abdomen. All right, so like I mentioned, doses have come down considerably, over 94% dose reduction in that time span, which as you would expect, right? Newer technology has come on, a different way of imaging. We're not using film anymore. We're using digital systems. We would just expect the radiation dose to come down. So with that comes a new way of thinking. If the shielding was used at a time when we use a lot of dose, higher dose, and also, of course, it was based on a different type of thinking that we were protecting against progeny, effects of heritable effects instead of cancer effects. Do we still need to use shielding? So a couple of years ago, there was a couple of papers that came out. A gentleman that I work with here at Cincinnati Children's, he and a couple of his colleagues wrote a paper saying that we don't need to use gonadal shielding. And from that time forward, myself and a handful of other people started looking at this, and a group within the AAPM came up with a position statement. I was actually part of this when they wrote it. It's, I think, about 2 years old now. And in part, it states, patient shielding may jeopardize the benefits of undergoing radiological imaging. Because of these risks and the minimal to non-existent benefit associated with gonadal shielding, AAPM recommends that the use of gonadal shielding should be discontinued. So there's two things in here I highlighted in color. The first is the use of shielding doesn't really provide benefit anymore, or at all. And we'll talk about that in a minute. So if there's no benefit, the benefit to risk ratio, let's talk risk. I will show you in a couple of slides how there are risks for actually placing the gonadal shielding on the patient and imaging. There is the potential that that shielding could actually cause more radiation dose to our patient. So let's talk about that. So because that benefit to risk ratio, whenever we talk about radiation, if there's a greater benefit from acquiring an image or using radiation, then we always say there's the benefit outweighs the risk. In the occasion when the risk to benefit ratio is flipped, obviously we would say, no, we don't want to use these, we don't want to use this procedure anymore. So we're very familiar with the benefit to risk ratio. We do this every day in radiology when our doctors are putting together their protocoling and they're setting up the patient scheduling. And there's always that question, is there benefit to these images being ordered? And whenever there's not, in a daily basis, we say, no, we're not going to do this imaging. So that mindset, I hope you remember that mindset, because that's the same mindset we're going to apply to this process as we talk through this hour. Let's weigh the benefit to risk throughout every one of these scenarios and let you answer that question. If the risk is greater than the benefit, should we discontinue? So following the AAPM position statement, we had just a list of other groups and societies that came out. The ACR, which is also American, well, obviously American College of Radiology, but it's also here, you know, in the US. Australia, Canada, several of the Canadian organizations, a couple more US ones, the Health Physics Society, Image Gently, which is a it's a group, I guess society is the wrong word. I'm trying to think of the word. It's an organization that we focus on, part of the Image Gently, we focus on describing best practices for imaging in kids. And then, of course, the Radiological Society of North America, RSNA, which is the major society for all radiologists here in the US, or basically North America, because it does include Canada. So these groups, all of them, came out with their own statement, and they said basically the same thing. They said, we agree with the AAPM. We also believe that we should discontinue using gonadal shielding. All right. The NCRP, which is the National Academy Society on Radiation Protection, it is the kind of foremost society on scientific analysis based on radiation protection. They came out, and after this position statement and after this publication from my colleague, Keith Strauss, when all of this happened, they came out and they did a year-long analysis. So it was a scientific analysis on the use of gonadal shielding, and then they've published their results. So this was an independent analysis, an independent survey, apart from all of the opinions in these position statements. And in the US, typically, you can write a position statement, you can write a paper, an editorial statement, you can do all of that. But a lot of the things don't change. The educational models, the rules, the laws in each of the states, those things don't actually change until, as an example, our NCRP society comes out and scientifically says, yes, it's a good thing to change. So this position statement of don't use gonadal shielding came out several years ago, but the NCRP statement just came out at the end of last year. And so for the most part, we're starting to see a stronger or a more rapid shift here in the US of moving away from gonadal shielding. And it is because the NCRP came out and said the following: the risk of heritable genetic effects are now considered to be much less than previously estimated. In fact, if you look at all of the data coming out of the Hiroshima Nagasaki patient population, and of course their progeny and their progeny's progeny, so we have several generations that have come from the survivors of those two atomic weapons, there has never been evidence of mutagenic effects passed on to their progeny. And so as time has gone on from 1950s to now in the 2020s, in this new decade, whenever we talk about risk associated to the gonads, we do not talk about risk associated hereditable genetic effects. We only talk about risk of cancer. So when we talk about risk to gonads, we talk about the risk to the individual, not to the future generation. And then, of course, I already demonstrated this, but improvements in technology since the 1950s have resulted in up to 95% reductions in the absorbed dose to the pelvic organs from radiography. So, and then gonadal shielding can and often does obscure portions of the pelvic anatomy, and may obscure important findings on radiographs. This limits the practical dimensions and area of the shield. So what they're saying here is the placement of the shield is never perfect, and we'll talk about that in a moment. And because we're looking at the pelvis, especially if we're talking, say, female anatomy, where the shield is going to be central to the imaging for the ovaries, whereas, of course, it's more inferior for men when it's covering their testes. But when it's in the field of view, when it's in the image, it has the potential to cover up important anatomy that is being used by the radiologist to make their diagnosis. And because of that, over time, these shields have actually shrank so that they could minimize the collateral damage of covering up important anatomy. And therefore, they've become less and less effective with time because the shields get smaller and smaller. And most of the time, miss covering up the gonads. All right. So despite adherence to practical guidelines by technologists, gonadal shields may not completely shield the gonads in the majority of patients due to the limited area of the shield and normal variations in patient anatomy. This is especially true for women. The ovaries are not exactly in the same location every time. And obviously for men, there's variation too. And so because of the inability to standardize the location of these shields, it's become very difficult to do it correctly over time. All right, and then finally, what I will show you going forward is these organs that we're talking about, the gonads, they're inside our body. Now, I know for men, testes are, technically outside of the body, but the point here is a lot of the scatter radiation. So if you image into the abdomen, once the photons enter into it, they're going to scatter. There's a lot of scatter. We talked about this for the last couple of weeks that's why we use grids, right? The grids reduce the amount of scatter going to the detector so that we can get good image quality. But that scatter, as it enters the body and moves around, because the organs are central, or the ovaries are a little bit more central, for example, they get a lot of radiation from nearby tissue scattering into the ovaries. And the same can be true about the testes. Even though the testes technically are, outside of the body, they get a lot of scatter coming out of the body, the legs and, of course, the pelvis. So the point here is just because you put a shield there and that shield technically stops all of the primary radiation coming down incident on it, the radiation coming down around the shield that's not stopped will scatter, and it will scatter into these organs. All right. Another thing that they talked about that risk is gonadal shields can interfere with the use of the automatic exposure control, the AECs. And therefore, they can actually cause radiation to go up when we image with AEC. And so if you put the shield, so here these little dashed lines represent areas of where the ion chambers for the automatic exposure control systems would be located in these images. So if you had these patients on your table and you've located them such that, maybe you're looking at the female and you're looking at the inlet here of the pelvis, and you're using either the center AEC chamber or either the left or the right, if you place a shield over here, it's going to cover that AEC. It's going to cover that ion chamber. And therefore, the system is going to think it's a very, very, very dense or very, very thick patient. And so it's going to turn the MA really high. Now, the shield is covering, in theory, covering the gonads, but it's not covering the colon. It's not covering all of the other anatomy that is potentially in the field of view. And therefore, other anatomy is going to get a much higher dose. In fact, when we look at the weighting, the sensitivity, the tissue sensitivity weighting factors, these are a calculation of what we think these tissues are relative to other tissues. So this whole thing adds to 1. This tells us roughly how sensitive these organs are compared to others. And so colon, as I mentioned, which is obviously present down here in the pelvis, the colon has a 12% weighting. The gonads have an 8% weighting. And I would just point out that the gonad weighting has done nothing but go down in time. And that's because it originally was a high weighting factor because we thought there was heritable effects, i.e. genetic or mutagenetic effects that would pass on to our progeny. Because that has never manifested, every time they assign a new weighting factor value, 2007 being the most recent, and so they're actually coming up due probably in the next decade for new ones, that value, that gonadal value, that 8%, 0.08, that's going down every time. But the point here is if there's red bone marrow in, say, the pelvis, and there's colon, these two things are at 12%. There's bladder here, 4%. And so there are all of these things, skin and a few other things that are in the field of view that are getting radiated too, and they actually have higher sensitivities to cancer induction than do the gonads. So using a shield can potentially be a very big negative. So let's talk about these shields. Gonadal shields are typically 0.5 millimeter of lead. So they're very effective at stopping primary radiation. So when you place the gonadal shield here on this young lady, the photons coming in incident on this are not going to pass through to the body. And that is why they look on the radiograph very white, because the shield itself absorbs almost all, if not all, 99% of the photons. And the same can be said about a man. You place the gonadal shield, the shielding on the patient anatomy, and once again, you see it's almost perfectly white. That means it's absorbing 99 to basically all of the photons. So when properly placed, yes, the shield will do a very good job of cutting down the primary photons incident on the gonads. So there was a paper that I reviewed, and that paper reviewed 18 other studies. So it's a meta-analysis of 18 studies. So they looked at over 3,000 radiographs, and they found that 85% of these 3,000 radiographs, the female shielding, the gonadal shielding for the female was mispositioned. So this is just an example from that study. You can see that it is relatively difficult to properly place it. Now that kind of makes sense, right? This is what the technologist sees. They see the female anatomy from the outside, the exterior. There are landmarks, of course, that we can use, the bony anatomy of the pelvis. Obviously, they are instructed to place this over the inlet of the pelvis. And that's in theory where the gonads are. But as you can see, jumping back to this one, that's not always the case. Now, was it just that this was maybe not done properly? Yeah, maybe some of this was a little sloppily placed. But the other comment I would make is if you look at these, the different shields, they're all different sizes, they're all different shapes, and they're all different. And so you have the potential to cover up surrounding anatomy quite extensively. Now, you might think, how can we misposition a shield for men? Their gonads are exterior to the body. There's a pretty good way of detecting where the male gonads are. We can generally visualize it. But in this meta-analysis of over 3,000 radiographs, 52% of male shielding was mispositioned. And here's just a simple example. The shielding was placed way too much inferior to the gonads, completely missed the testes. So mispositioned shields, once again, will obscure potentially important anatomy, more specifically for female. But if the shield had been placed superior, then it potentially could have done the same thing. So let's talk about the fact that you and I and everyone in between, we're all different people. Specifically speaking, let's talk about women. In a paper here that was published in 1999, so this is a not new knowledge. This is something that we've known about for 2 decades now. Gonadal locations were observed. They used ultrasound to identify exact locations, and they looked at it from person to person, looking at the variation, and every one of these circles represents the location of. So 70 adults were looked at, 128 ovaries were positioned or identified in space, and you can see there is a considerable variation in the location of the ovaries. And so if we were to assume we could place the shield perfectly over the inlet, you would see that we are still going to miss some gonads. Now, obviously, the majority are here central, that I will not deny, but there are still quite a few that fall outside of that area. And that is assuming you can place the shield perfectly over the inlet. So the other thing we did, so this is now myself and 2 of my colleagues at Cincinnati Children's, we did a study a couple of years ago. Actually, it was just published last year, in I think December of 2020. And what we did, it was a Monte Carlo study. So we had a couple of phantoms. We had these anthropomorphic phantoms that I've talked about in the past. So they simulate different tissues in the body, bone, of course, soft tissue. And we had an adult male, we had an adult that was both male and female. And we had a 5-year-old and a newborn. And so in every one of these, we were able to calculate the actual dose to the ovaries and to the testes. So ovaries shown here in this orange circle, testes shown here in these yellow circles. And we did that without shielding. And here you can see the color variation. The lighter the color, whiter the color, the hotter the dose. And as the colors got darker, going from orange, blue, purple down, that's when the dose was reducing. And you can see here, obviously, the radiation dose gets much, much lower as it penetrates through the body. We talked quite a bit about that last week. In fact, the amount of photons coming out the back end is really only about 1% of those incident on the anterior surface. Now here you can see when you place the shield actually over top of or anterior to the location of both the ovaries and the testes, you can see there's the shadow. And that demonstrates that the primary beam is mostly reduced. And I know it's a small image and it's small on your screen. And please forgive me for all of you out there that are colorblind, but there is actually color in here overlaid on this gray and white CT scan of the ovaries, of the phantom. And so there is actually scattered photons coming into this area, even though the primary beam completely cuts that out. So what we did is we wanted to know what is the actual dose to these organs based on proper shield location and then improper shield location. So here I'm just demonstrating that here's the 5-year-old and here is our little newborn. So these were, of course, you can see here the anterior posterior view, and then this is just a simple sagittal view, and you can see the full field of view as imaged, and you can see it without shielding and then with shielding, how effective the shielding is at reducing the primary beam. And you can see that here for the little guy too. So what we did is we took this and we simulated a shield in place, and then we slowly moved that shield anteriorly 2 centimeters, and then we would redo the simulation. And we did that for a total of an 8 centimeter shift anterior to where ideal location should be. So what were the results? Well, the results were that we found in the adult, ovaries received about 40% of their dose from scatter. And what you can see here is The 0 here on the x-axis represents the shield in proper place. So it's ideally placed. And then we shifted it 2 centimeters, 4, 6, and 8. And that's when you're looking to the right on this axis. You can see how the overall dose reduction is reduced to the point where definitely when you're about 4 centimeters or 6 centimeters off of ideal, so mispositioned, only 4 to 6 centimeters, you can see there's basically no dose reduction at all. The shield itself is not in any way contributing, maybe 5 to 10% at most contributing to dose reduction. And the 3 colors you see here are the 3 phantoms. And then the top one here is the ovaries. And then, of course, you see here the testes at the bottom. Now, it's a little bit more gradual of a reduction here on the ovaries, and that is just because there's a lot more scatter from the abdomen itself. There is a much more distinct shift. So if you offset the shield only by 2 centimeters over the testes, you're still getting about 90% dose reduction. But you go just another 4 centimeters, you can see how it almost completely goes away. And that just demonstrates how much the shielding affects the actual dose reduction because of where the location of the testes are being outside the body. We saw that for the ovaries, once again, for kids, for pediatrics, so looking at our 5-year-old and our newborn, 30% of the dose to those ovaries come from the scatter. And here I just gave you all the numbers, but I'm not going to go over all those. Now, for the testes, for the male, the dose reduction was about 85 to 90% for adults. Properly placed shields over the testes reduced the dose by 85 to 90% for adults, and 10 to 15% of the dose from the to the testes came from scatter. And we just kind of talked about that. So the ultimate result was that if you're basically 6 centimeters off center, off of mispositioned, you're basically cut the effectiveness of the gonadal shields to 0. And that was the same for both testes and ovaries. Basically at 6 centimeters, these basically go to 0. So gonadal shielding use does not contribute significantly to reducing the risk from exposure. And the gonadal shielding may have an unintended consequence of increasing the exposure, which we talked about using AEC. Gonadal shielding may obscure important anatomy, leading to loss of valuable diagnostic information. So that was the benefit to risk ratio that the NCRP and others, like I saw that I demonstrated in our publication, how we demonstrated that we don't see a benefit because a lot of you can't actually cut all of the radiation dose to gonads. Just no matter how many shields you put on top of the patient, you'll never reduce all of that in scatter. And the risk factor we felt is higher than the benefit. And so there is no benefit, but the risk is higher for loss of diagnostic acuity. So, we basically discussed this. Dose of the gonads has come down quite a bit over the last 7 decades. If you want, here's a website. So when you get a hold of these slides or watch this again another time, you can go to this website. The AAPM came up with an organization called CARES. It's an acronym. It's basically, if you go to this website, it gives you a whole lot of information, both scientific and other, that gives you information about gonadal shielding. So if you want to know more about this, go to this website. There's also a URL here for the NCRP. And this is a trifold. In other words, we have the CARES group created these documents and stuff that now I know they're in English, but for people here in the US, they can hand out. So if a parent or a patient walks through the door and says, why aren't you doing gonadal shielding anymore? There's information that they can actually hand out and say, well, if you're interested, things have changed, blah, 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 blah. Here, you can read more about it. So all there. My guess is if you were interested in getting that into Thai, you could reach out to this group. I actually know the individuals that are the chairs of this group. They're wonderful ladies. They would probably be very willing and very, very willing to work with you. Okay, so we talked a little bit about gonadal shielding. We spent a lot of time on that because that was the question that Tanya had. So let's talk a little bit at that point, I put together my slides and I thought to myself, okay, now we'll transition this to mammography. But I thought to myself, so many people, once we started taking away the gonadal shields, they started asking other questions about, well, what about the other shields we place on our patients? And obviously parents have shielding because they're standing next to their kids. Why didn't we remove all of the shielding? So let's talk about all of the other stuff going on here. So when we are in the same room, when the x-ray machine is on and we're imaging, generally speaking, we, the staff and our parents and the caregivers, they will wear lead. And this is for a lot of reasons, especially in pediatrics, where they have to kind of be there. Sometimes they actually have to hold the kid in place. Other times they're there just for emotional comfort and support. So how much scatter radiation does do these kids and or adults, when they are being imaged, produce? How much scatter is coming off of these individuals, the patients, into the room? And then, of course, incident upon the staff and or parents or anyone in the room that are wearing these lead aprons. So the question is, do we need to wear these lead aprons? Is there a sufficient amount of scatter in the room? So this is a work that myself and Keith Strauss did at our institution. We took our anthropomorphic phantoms. Once again, we have the adult, the 5-year-old, and the newborn. So we're just kind of testing this across different body sizes. And we measured the amount of scatter coming off of a head, a chest, and an abdomen/pelvis when you're doing a radiograph. We also used, because these phantoms, as you may recall, they don't actually have extremities. So we had to use just some really simple PMMA blocks to simulate the extremity. And we've talked quite a bit about using those in fluoroscopy and radiography. And I've talked about how very versatile they are. You don't necessarily need these crazy expensive anthropomorphic phantoms. If you just had if you just stacked up these PMMA blocks, you could do this exact same experiment for yourself if you're interested. And what we did is we exposed these phantoms. We used the standard clinical protocols. Therefore, we did not modify in any way the KV, the MA, and we actually had some technologists come in and help us set the field of view as if it was an actual patient. So here's the example. This is the 5-year-old phantom where they set the field of view. You can see the light field being projected on it. You can see the marker there for the centering, for the head, the chest, and the abdomen pelvis. And here you can see our ion chamber at the end of this table. We measured perpendicular, we measured parallel, so kind of at its foot, and then we also made some measurements right at the point where the photons would be coming into the patient. And we made all of these measurements so that we could get a feel for how much scatter was coming in as a function of the amount of photons or radiation incident on the patient for imaging purposes. Now we placed the ion chamber all the way out here because we actually needed the photons to be coming in parallel. If you got it closer, there's a divergence, and so it changes the imaging paradigm. That said, we imaged out 100 centimeters, and then we used the inverse square law to correct to 25 centimeters. In other words, all of the data I'm going to show you is with reference to 25 centimeters, which is about where you, if you were a staff member or you a parent or a caregiver or someone, were standing if you were helping, say, hold a patient, or if you were just sitting there talking to them, helping them stay still. All right. So here are the results from this. So this looks at the percent stray radiation measured at 100 centimeters from the X-ray beam compared to the radiation that's going into the phantom, or in our case, the patient, a patient. For the newborn, a 5-year-old, and adult. Now, for the skull, abdomen, thorax, forearm, you can see the highest amount of scatter coming off of any of this is for the adult, which would make sense. It's bigger, so it produces more scatter. And we're talking about 0.3%. That's the highest amount. So when you look at the total amount of photons going into the patient, only 0.3% of them are coming off the patient or out of the patient. So the amount of scatter is actually pretty darn low. So what does that mean? in the US, we have a law that says if you're in the hospital and you're around X-ray equipment, a member of the public, so not a worker, but a member of the public, can only receive up to 1 millisievert per year of radiation exposure. So if that is the absolute limit that they can be exposed to, how many procedures could they, in theory, stand next to? So how many times, if you had a patient, let's say you're a mom or a dad, and you have a 5-year-old child, how many times could they go into a room, stand 25 centimeters away, so right next to the patient, during a skull or some imaging in the head, abdomen, thorax, or forearm? And that's what these numbers represent. So in that example of a 5-year-old getting, say, an abdomen, one view abdomen x-ray, they could, in theory, stand next to this patient 95 times and never exceed this number. So they would not actually be breaking any laws up to all of these numbers. So for a newborn, which is probably where most parents are physically at the side of the table helping the patient hold still, because they're literally holding their arms down or holding their legs down because the kid's trying to get away. You can see that we're talking about nearly 1,000 times. And to my knowledge, I have never seen a patient get 1,000 abdomen exposure x-rays in 1 year. I don't think it's ever happened. Now, this, of course, is all just x-ray, just plain our radiograph. And if they're helping an adult, because, we do have to help. Some adults may have maybe like Down syndrome, or they have other developmental issues, so that adults might have to be in a room with an adult to help that patient get imaged. We're still talking that maybe potentially they could be there for 18 abdomen x-rays and not exceed this number. Now, what about you and me as a staff member, as someone that we carry our badge, we got our radiation badge, we got it clipped onto our collar, we got it onto our lanyard or whatever when we're walking around the hospital. Now, in the US, once again, forgive me, I don't know what the laws are or the rules are in Thailand, but in the US, as a radiation worker, someone that carries a badge, I'm allowed to receive 5 millisieverts per year. Now, we also have a rule that says if you're going to exceed 10% of that, if you're going to, so 10% of that value, so 0.5, if you exceed 10% of that value, you need to have a badge on. If you are a staff member, so you work in the hospital, but you will not exceed 10%, you actually don't have to wear a badge. So that's why some people will go into radiology, they will work in the area, like a nurse or something, and they aren't badged. That's just how we do it here in the US. So the question is, once again, how many procedures could they help out with and not actually need to wear shielding or wear a badge? So they would be completely legal to be exposed these many times without breaking any rules. And here you can see that the number is much lower, of course, because we're talking only 10% of this value, so 0.5 millisieverts per year. You can see now for a 5-year-old, it's only a couple. For adult, it's less than 1. But for a newborn, which is generally speaking when like a nurse or someone needs to help out in the x-ray room, we're still talking numbers like around 20 or so, maybe 80 thorax chests. So the point here is the amount of scatter coming off of the patient when they are being imaged in an x-ray room, so we're talking DRCR imaging, it is very, very low. And so technically, the parents that when they walk into the room don't necessarily need lead per certain rules and laws in our country. And technically, the staff could probably get away without it too. That said, I need to just say this. In the US, we have a law that says if you're in the room, you have to wear lead shielding. It's quite literally written in as a law. And so even though we did this study and we did all these calculations, we did this to demonstrate that this law is really unnecessary. And maybe in the future, it'll go away. It would be simpler that when a parent walks in, they don't have to don all of this lead. tends to make people scared. And then obviously you have to clean it off. And in an era of COVID where everything has to be highly sanitized, this would just be one less thing that the technologists have to deal with every time a parent or a caregiver walks into the room to help a patient get an x-ray. One thing we have noticed as we've talked a lot about fear of radiation, people that don't understand radiation, they fear it, of course. And so when you walk in the room and you already are afraid of radiation, and then we ask them to cover themselves in lead, it perpetuates this fear that the x-ray that this procedure, this exam that we're about to perform on one of their kids or, someone else, it could be an adult, it's perpetuating this idea that it's very unsafe. And we know in radiology that of all of the imaging that we do, x-ray imaging is probably one of the least risky. It's so low dose. And so we want to try to get away from us as radiologists, as people working with radiation, perpetuating a misunderstanding of radiation. Now, I'm not trying to say that all radiation is safe. I'm just trying to say that for what's happening in radiology, generally speaking, that benefit is so much higher than the risk that we do consider it okay for this type of exposure. And we just don't want people to have that fear, because it really does prevent, and sometimes in real cases, I've dealt with this in our hospital where parents will not let their kids get x-rayed because they are afraid of radiation. But we're talking about such low amount of radiation that the benefit is so much better than the risk. All right, so let's keep going. The next thing that you see is, for example, you're doing a chest radiograph. We will oftentimes strap some kind of shield around, say, their pelvis. We will place shielding outside of the field of view. So in this case, this young little girl is getting a chest radiograph, a lateral radiograph right here. This shield, there's no light. There's no light on the shield. That means the system is collimated to above the shield. The shield is not stopping any primary radiation. There is no primary radiation incident on that shield. So we're going to talk about, is that type of shielding necessary? All right, so out of field exposures, only scatter radiation is incident on organs outside of the field of view. We've already talked about this, right? This idea that if you're imaging the chest, the radiation affects the dose that we're giving to our abdomen organs, that's coming from inside our body. That's the scatter in our body. It has nothing to do with the radiation incident upon or striking our body. So there was a lot of work on this many years ago, and this was mostly calculated for dose to the conceptus or a fetus. So if we're going in and we're doing, say, a chest radiograph, let's say a 2-view radiograph of the chest, how much radiation dose from that exposure would be incident down into the pelvis onto, say, a fetus if a woman was pregnant. So we found, and not we, but the greater scientific community found that the organ doses outside of the field of view, of the direct imaging field of view, those organ doses depend strongly on the area of the imaging field of view and the distance from that field of view. So let's take this PA chest radiograph that we're doing here. You see in this infographic, the photons are incident upon the back, the PA, the posterior to anterior aspect of this image. We're imaging the chest. Now, like I said, this was developed back in the day when they were looking at conceptus dose. So here you see the uterus, but any organ down here in the pelvis, gonads, whatnot, or colon, stomach, anything down here in the abdomen can also be calculated using this equation that I'm about to describe. And so we're going to talk about the area of the imaging and the distance from the edge of the field to the organ. This is the edge field distance, EFD. So when you look at this equation, it's a very simple equation. We take the entrance skin dose that we can calculate here, and we've already gone over those calculations many a times the last couple of weeks. I'm not going to go over them again. And if you multiply it by this EFD correction factor, that will tell you how much the dose is to these internal organs. So let's just look at this. So I know it says depth of conceptus because like I said, this is developed for pregnant women. But this could be the exact same thing if you're looking at, say, the colon, the bladder, even the small intestines, or anything outside the field of view. We could be doing an abdomen here, and we could be looking at the dose to the breast or the heart or the lungs. It's all a matter of distance, whichever direction we're looking. So if you look at something that is, say, 10 centimeters from the field of view, the edge of the field, so 10 centimeters down from this top red line, if the organ is roughly 5 or maybe even 10 centimeters deep in the body, so somewhere midline to the body, we're talking about only 2% of the entrance skin dose. So the dose of these organs is only 2% of what the skin is receiving out here. Now it gets a little higher if we get closer, so 2.5 centimeters from the field of view. So if you're looking at maybe the transverse colon up here or the stomach, then of course the percentage is a little higher. Talk about 10%. But these are still low percentages in general. So rule of thumb, if your distance from the most inferior portion of the imaging field of view is greater than 10 centimeters, generally speaking, it's 2% of the entrance skin dose. If you're greater than 25 centimeters away from the inferior aspect of this field of view, then the dose is negligible. The dose to that organ is, you just basically couldn't measure it. So do we need to place shields kind of on the outside? So if we came in here, we're doing this PA chest radiograph, oftentimes people will place a lead apron back here covering the pelvis and the abdomen of this patient. That is not in any way stopping any form of radiation. It is quite literally doing nothing because all of the dose to those organs is coming from scatter. So are there other types of imaging, out of field imaging? The answer is yes. Let's think about dental. We oftentimes will drape our patients in these lead aprons. We might even strap a thyroid shield on their head. And then we'll take the intraoral x-ray tube and we'll place this lady's either going to have a digital, you can see it's a cord coming out. So it's a digital film or, just regular film. And you can see how it's pointing at her mouth, not down at her body. And so once again, the photons that are going to be incident on her body in this image, in this picture, are scatter. So when you look at the various different organizations in Australia, UK, the US, the European organizations, all of these groups all agree that there is no justification for the routine use of lead aprons in dental intraoral imaging. It's just, once again, that distance from the field of view down to any kind of organ down here, we're talking more than 10 centimeters, almost always more than 25 centimeters. If we're talking breast, chest, lung, abdomen, even gonads. Gonads are just, we're talking almost a meter away from the mouth. There is no scatter down there. And so unless you're pointing that intraoral tube down at the body, there is no primary radiation going down into the body. So that's the same also for thyroid shields. Even though the thyroid is that much closer to the mouth or, to the actual intraoral or the cavity of the mouth, the fact of the matter is you can reduce the dose from the scatter to the thyroid and any other organ in our body more effectively by using fast speed film, E or F, or using new digital detectors, because you can reduce the MA really low with these new faster films and digital plates that we can place inside the mouth, using usually a fraction, sometimes a tenth of the radiation dose that we have done in the past. And so therefore you can place a thyroid shield over the patient, but once again, it's just dose coming down from the scatter. So the thyroid shield is not preventing anything because thyroid shields only prevent radiation that's hitting it from the outside. It's not preventing anything from coming down into the body. And so you will save more dose of thyroid by using new technology and collimation. Now, I know you can see in these images, there is no collimation. That's a circular collimator. That's a circular orifice. That is the vast majority of what intraoral imaging, the imaging in intraoral dental we use today. That said, from the 1950s forward, the various different dental organizations have been recommending using longer PIDs, these position indicating cones, and they've been recommended using square collimators. The film in dentistry is always rectangular. It's never circular. It's always rectangular. And so that's the whole concept of this collimator. If you can do a good job of matching it up so that you're not getting film cuts, but the radiation is actually going through the square collimator, the rectangular collimator, into a rectangular detector, you're reducing patient dose and you're reducing the field of view. So therefore you're reducing the amount of scatter coming out of the mouth into the rest of the body. So we've talked about internal. Once again, these shields do not prevent against internal radiation. Definitely there's no gonadal issues. And every one of these organizations said that it's pointless also for pregnancy. And that's just because, I mean, looking at this, if this young lady here was pregnant, I mean, her fetus would be down here. And the amount of scatter from here to there would be negligible. So you just don't need to do it for pregnancy purposes. What about other types of imaging in the dental clinic? Well, we have panoramic or cone beam CT. So now we got the system where the tube will actually spin around the patient. Once again, there is no evidence supporting routine use of lead because once again, the photons are aiming at the mouth, at the face, not down at the body. In fact, there is a potential for negative. If you go out in the literature, there's enough publications out there to justify this. But sometimes when people place the thyroid shield on the patient, that thyroid shield can actually infringe upon the imaging, especially in the jawline down here. And so there, when you look at the newest guidelines when it comes to doing panoramic and cone beam CT, they recommend not using thyroid shields. Because if this happened, and for whatever reason they need to see this, you're going to have to image this patient again. Not only did you not save this patient dose, you doubled their dose. And I just have to point out this wonderful picture of this young lady wearing a lead apron and a thyroid shield. That thyroid shield is not covering her thyroid. And so how many times do we give our patients shielding, but we don't take the time to help them put it on properly? So first of all, the shield's not doing anything anyway. But second of all, it's definitely not doing anything when it's not being worn properly. Now, what about cephalometric imaging? This is the one exception. I told you there's an exception to everything. So here's an exception. In cephalometric imaging, of course, the patient, so we're looking at it laterally, the scanner transitions, so the scanner detector goes along the side of the patient like this. It just scans along and we get a nice lateral projection of the face. In that case, because the tube is always constantly pushing radiation one direction, if you put a blocker around the thyroid, in this case also the cranium, you are going to reduce dose to those organs. Now, as long as these shields in no way infringe upon the diagnostic quality of the image, in other words, not covering up anatomy that you need to see, then those shields are actually preventing dose to those organs. So in this case, sure, use it if you want, but you got to be good at setting it up. Because if you missed it, that say you're using this cranium shield and it comes down, if it's too low, too high or whatever, and same thing with this thyroid shield, if it's too high, you're going to infringe upon imaging. Now, I would make the argument that once again, dental imaging is incredibly low dose. And the cephalometric imaging is relatively speaking rare compared to intraoral or even panoramic or cone beam. We just don't do as much cephalometric imaging. Therefore, the dose to the risk to a population to those people in the Thai, the Thai population that come in to get this imaging is pretty darn low. All right, still talking out of field imaging. So now let's talk mammography. Now, there was about 10 years ago here in the US, we had one of those medical doctors that is a talk show host. So he goes, it's a he in this case, He went on and he has a talk show every afternoon, and he goes on and he gives medical advice to everyone. And for whatever genius reason, he said, hey, if you're going to go get a mammogram, you should wear a thyroid shield. He made that statement. And then overnight, all of these women going in to get mammograms immediately started demanding thyroid shields. And so various different organizations, but mostly the society, for example, Society of Breast Imaging, the people that deal with imaging and mammography every day, they had to finally come out and say, listen. You do not need to use a shield on the thyroid because of the amount of radiation incident upon the thyroid. They did scientific studies. They looked at this. The only type of radiation that's incident on the thyroid from mammogram is radiation that's coming from the X-ray tube. Because obviously when the lady comes in and she's on the machine, so she's got her breast in position, her face, her thyroid is right up here next to the top of the machine. That's actually where the X-ray tube is. So there is a potential for X-ray radiation or leakage to come out of the X-ray tube and be incident upon her face or her thyroid. And so when they looked at that, they found that there was only about 0.005 milligray that was incident upon thyroid. That is equivalent to 30 minutes of natural background radiation here in the US. Now, I know natural background radiation is much lower in Thailand, so it would be a little bit more for your population, relatively speaking. The point is that thyroid shield is just unnecessary. And in the off chance, the small chance that that thyroid shield would infringe upon the imaging, it would be a negative. So generally speaking, the thyroid cancer risk, the risk from imaging using a thyroid shield is greater because it could actually infringe upon the imaging. The minimal effect from the amount of radiation that you're actually reducing using the thyroid shield, it just doesn't really warrant the use of it. And then the other thing that these publications in this society talked about was the fact that most mammograms are being done for women that are between 40 and 80 years old. Now, I know some younger women can get it if they have a higher risk factors for breast cancer. And so their risk of cancer from thyroid will go up with age. It goes up with younger age. But when you get to the 40s and the 80s, your risk of thyroid cancer is really low. Less than 1 in 17 million patients will get cancer from thyroid. Will get thyroid cancer. So you can prevent 0.005 milligrams of radiation on the thyroid using this shield. But to what effect? If that photons did go in and did actually irradiate the thyroid, you only still stand a 1 in 17 million chance that photon could actually even potentially cause cancer. So it's the risk factors are so low. And therefore, all of the various different organizations, the ACR here in the US and the Society for Breast Imaging, all of these societies came out and said, no, you do not need to wear a shield for a thyroid shield when you're doing mammograms. So let's just do a quick review of all of these. So once again, we talked about how internal organs receive scatter from radiation dose when it's not. Internal organ dose is from scatter radiation, not directly irradiated. And this is all based on the distance from the edge of this imaging field of view, that light, to whatever organ you're considering. And we've known this, as I said, for a long time, since the 1960s. So out of field of view organ doses are negligible for both X-ray, so DRCR, dental, mammo. What about CT? So let's just briefly talk about this. This practice has basically gone out of vogue, but for a long time, for probably about 5 years ago, this was pretty routine. And it was primarily for breast shields and eyes, and shielding the eyes for eye lens. And these shields came in all shapes, forms. It just depended on how and what your organization, your hospital used. So what happens? Well, what's going on? So first of all, these shields are usually made out of bismuth, so they're called bismuth shields, not technically lead. And then if you would just place them directly over the eyes, or you'd place them over the chest. Whatever age, obviously this is a phantom, so there's a young phantom, so there's no actual breast anatomy being demonstrated in that image. So let's talk. Do these do these shields do anything to reduce the dose? Yes. Breast doses can be reduced 85 to 90% when you place these bismuth shields over top of the chest during CT of the chest. And then eye lens, the dose to the eye lens will go down by about 35% when you're actually directly scanning or doing a CT scan that covers the eyes. But do they affect image quality? And the answer is yes. Breast shields have been shown to reduce the contrast to noise ratio and the CT number accuracy in the region beneath or underneath the shield. Eye shields will increase noise to the globe of the eye by about 23%. So in general, most of the publications that came out like I said, about a decade ago, they said that, okay, yes, the dose can go down, but the fact that these shields can increase or decrease image quality, that benefit to risk ratio is out of control. It is improper. Because if the benefit was always at the dose reduction, then yeah, we'd still use them. But if the fact that there's a risk that the images that we give the radiologist are undiagnostic, what are you going to do? You have to re-image the patient, but without the breast shield this time. So now you've doubled their dose. You may have lowered the breast dose for a little bit, but you've increased the dose to everything else twice. Are there better ways to reduce dose in CT? The answer is yes. And a publication came out from Wang and some of his colleagues there at Stanford University. They looked at just standard chest CT of this is eye and this is the chest. So the blue is just a standard, no shields, just normal imaging technique. And then the red is if you actually place the bismuth shield in place. And then there is the green, which allows for organ-based tube current modulation. And we talked about this, how some CT vendors will actually, as the CT scanner comes across anterior to the body, over the eyes or the breast, or even the thyroid in some cases, it will reduce the MA over the anterior sweep, and then it'll go back to normal as it spins around the body. And there is one vendor that will reduce the MA and actually increase the MA as it goes behind. Point is, organ dose modulation will reduce the MA to the anterior organs, be it the eye lens. It was developed also for thyroid, but specifically to what we're talking about, the breast and the eyes. So you can see here, the organ dose modulation, this green value, was basically equivalent to the dose reduction that we saw with bismuth shielding. You could also just simply use a lower MA imaging technique and match it. So the point here is you can actually get good dose reduction for these critical organs without using the shield itself. Here you can see that we learned when they started using these shields that you can't actually place the shield directly on the face. You have to put pads underneath it because you get this change in CT numbers and you get this artifacting right behind the shield. Here you can see image quality is a phantom, no shielding, standard imaging, but now organ dose modulation. So the MA is reduced here anteriorly. And then just if you dial in a lower MA, the overall image quality, I would argue, here in the globes are the same. If anything, it's actually a negative when you put the bismuth shield on. And the same can be shown for the chest. All right, so in general, setting up a proper CT protocol is as effective as using bismuth shields. Using modern tube current modulation will give you good dose reduction without artifacts, without change in CT numbers, and without increased noise. So the modern scanners that we have, X-ray, dental, mammography, although we're not really talking about that, I guess, as much, and CT, they are so much lower dose now, and the technology that we have provides us a lot of tools to reduce the dose to critical organs, be they, the gonads, be they eye, lens, breast tissue, thyroid. So we can use this new technology to reduce the dose in these areas instead of dealing with all of the various different lead or bismuth type shields. And once again, these types of shields that we place outside, exterior to our body, only prevent radiation when the radiation directly strikes those shields. It does nothing, these shields do nothing to reduce internal dose to the organs from scatter. So the question that we always have to ask ourselves is the shielding being effective? or ineffective. So if it's ineffective, we could easily say, yeah, we don't need to use it, right? If it's ineffective and harmless, yeah, maybe we could use it if the patient absolutely wants it because they are scared, they're worried, and it makes them feel better knowing that they have a lap apron on when you're doing a chest radiograph. That's okay. If that makes them feel good, and it's not infringing upon the image quality, go for it. It reduces anxiety. That's a good thing. So I meant to forget to mention this. In our institution, we are largely moving away from using a lot of these out of field shielding. We're definitely moved away from using gonadal shielding. One day we'd love to stop handing out lead to all the patients that walk into our room, but until the laws change in our state and our country, that will persist. The point here is when a patient asks, we do give them lead. We're not trying to cut them off cold turkey here, but we do counsel them and we do instruct them and we give them information so that they can take home and read, trying to help them understand that they shouldn't be necessarily afraid of radiation, especially in medical imaging. All right, so I went a couple minutes over, but this was meant to be a very comprehensive review of overall shielding. And so if you have any questions, I'd love to try to answer them.
Wow, thank you so much, Sam. This is really practical for us. And it's like a daily practice thing that we usually get the questions from the patients and we among ourselves, like, oh, should we like shield the patient or not? So final answer from you is we don't need to shield the patient. And even
technically, no.
Yeah, and even like this is like a for radiograph, and even for like a parents that come into the room to help with the patient stuff, we don't even need to shield at all.
Well, so the answer is no, it's not really necessary, but where you work, yes, you have to because it's a law. I don't know what the laws are in Thailand, for example, where you may not have a physical law that says anyone in an x-ray room has to wear shielding. If that law does not exist, then that's something that I would encourage the radiologists, the medical physicists, and your technologists to talk about. Is it necessary? I always encourage you guys to take the results. You can go back and look at my references and our publications. We've done a lot of this work. There's others out there that are published on this. So, I encourage you to make your own decision and you can try to replicate our results. But in the end, like I said, from the very, very beginning, I truly believe these types of shieldings are ineffective.
Yeah. So this is like for the patient who come to get a scan, right? But in case that the patient come for the CT and she does not know that she's pregnant, let's say like we did a scalp view and we don't really know because like a fetus is very small. So in that case, maybe we scan like a one face already and technology just, okay, that is a fetus. I should stop. I cannot do anything more. So what is like the practical point or what should we do? Because right now, Napapong is the one that we get contact, like, okay, call Napapong, ask for his help and those things. Yep.
Yeah. And so, there are times where we actually will image a pregnant woman. We will, let's say we're imaging her head. We just had in our institution a couple months ago, we had a young lady that was pregnant, but she needed her head imaged. There was no question in our mind. We went forward. We did the CT of her brain. The amount of scatter coming from here down to here is almost negligible. I actually did the calculations. We also actually imaged her abdomen because we needed to, for her health, the benefit to the mother was we needed those images. And now she wasn't real far along, and she was actually a tiny little girl. So the amount of radiation that the system used was really low. In our case, it ended up being less than 10 milligray to the fetus. And 10 milligray is, when you look at the guidelines here in the US for imaging and exposing a fetus to radiation, anything less than 50 milligray is just negligible. It's just no risk. There is a gray area between 50 to 100, but there's never been medical evidence showing that if you did image and you exposed a fetus to say 70 milligray, there's no real direct evidence that there would be some problems with that. After 100, yes, we do know, and that's based off of Hiroshima and Nagasaki. We know high levels of radiation incident on a fetus in utero can, have some effects. There can be IQ deficits, there can be microcephaly, there can be a few other things, but that's really, really high dose. Today in radiology, we just don't image that high. And when you go in and even a large patient can get an abdominal image or CT of the abdomen or pelvis, and they'll get a CTDI vol value of somewhere in the 10, 15 milligray range. That when you actually take that value and then use it to calculate the dose to the organs, it's much lower. Obviously, remember, CTDI vol is not patient dose. But the point here is, if it's medically necessary, then the amount of radiation we're using is always, it's low. And so most likely there's not going to be an issue. Now, do you want to go in and do a 3-phase abdomen study when the lady's pregnant? Probably not, because that is probably a lot more radiation that you really should use. But if you're doing like a chest CT or a head where it's completely out of field of view, then you could go in and you could lay an apron over her belly, but it won't do anything because the radiation is coming down from her head, down through her chest, into her abdomen. And so there is literally nothing we can do to help them to stop the radiation. So when we image for a pregnant woman, we talked about this actually a couple of weeks ago, there are techniques we can to lower the MA, to lower the exposure. We can use those organ dose modulation techniques if we have to, which reduces the dose anterior. So that's obviously where the baby is. So there's ways for us to do this to reduce the potential for risk. And that can be said about an x-ray. If you're going in a digital radiograph, this actually happened to my wife when we were first pregnant with our first child. She got in a car wreck and she got real bad whiplash. So they went in to give her an x-ray of her neck. And so she said, "Oh, I'm pregnant." And when they did that, so they went in to set her up. They're like, "Oh, she's pregnant." And they put, I think, 3 lead aprons on top of her belly.
Really?
And she told me afterwards, it hurt more to stand there with her neck hurting from a car wreck with all this weight pulling her forward. And she was being forced to stand back and hold her neck upright. But all of that lead did nothing to prevent the photons from hitting my kid. So it's so, you know what I mean? It's just like, we have to just think about this logically. And so as technologists, you in that room, you are the first people to think about that. And if you know that you're imaging up here or up here, and the baby or whatever we're talking about is down there, you just know that there is really no risk to that. And so we can, in that case, I wish what would have happened was the technologist would have said, "Oh, congratulations, you're pregnant, but we're going to image up here, so you don't have to worry. There's not going to be any radiation down here."
They should call you, maybe maybe she should hand the phone.
Yeah, sure. I can just be on call all day, every day. I might have to learn how to speak Thai though, if I'm going to help you.
Yeah. So, and one thing that I just learned today is about you have many types of the shielding, the bismuth and maybe the lead apron that we normally use. So, which means if we need to use it, it's it depends on the body part, or is it depends on the study, the scan, like a CT and radiograph?
Yeah. So, yeah, we've been the majority are lead. Gonadal shields are lead. Most of what we use in X-ray, and DRCR and radiography, it's actually not lead. It's actually plastic that's impregnated with lead. And that's why you can fold it and move it and bend it. Regular lead would bend and break in half, but it's lead equivalent. And, it's just, it comes in all different shapes and sizes. And so it's specific to the use. You saw that one image of breast shield where they actually had it come over the chest, and it just covered the 2 locations of the breast, where there was another one that laid strapped across. So, they all come in different shapes and sizes, and,
So it does not different.
Yeah. I mean, there's really no difference in what it's doing. If the shield is in place, so we've got a bismuth breast shield in place, we're doing a chest CT. Every time the CT scanner goes across anterior to those breasts underneath that shield, they're getting very, very little radiation. That is a fact. That is true. But when it spins around and shooting up through the body, guess what? You're exposing the breasts because you don't have shields back here. If you wrap the patient in lead, guess what? You're not going to image anything there. And so what are you trying to do as a radiologist? You're trying to see. Now, maybe you're not looking at the breast tissue in a chest CT. Maybe you're looking at, of course, the lungs, the lung parenchyma, the mediastinal soft tissue. But we have to image through the breast. And so we just have to do our best to reduce the dose to the critical organs and just keep going forward. And I'll say this 1,000 times more. The technology we have now is so good. It really does reduce the dose. Now, I know there are places in this world, and I know there are places here in the US that they just can't afford fancy new CT scanners. They're using scanners from 10, maybe even 15 years ago. It's harder to believe that, but that's just what they've got. You can still do stuff with those type of scanners. You can still reduce the dose. You're limited. You definitely are. But as you keep new scanners in your hospital, so if you replace them, say, every 10 years or whatever, you're going to have new technology to do amazing things to reduce the dose to our patients.
Yeah. So lucky us, in Thailand, we don't have Dr. Oz show who can tell about that. Right? About like the thyroid shield for the mammogram. So but come back to the questions here. So how do you educate the patients or the population to know about the gonadal shield is no longer needed?
Yeah. So like I said, one thing you can do is go to these websites that I write around. Where did I put those websites?
Like the website things and just like a hand information.
Yeah. So at our institution, at our hospital, I wrote basically just a one page. It's a 2-sided page. It's a trifold document that we just hand out. The other thing I do is I have my business card. Every technologist has my business card. And if a parent walks in and it has a question, we teach our technologists. I have a PowerPoint. I go through all the kind of the same things we talk about here. I give them information because 99% of the time, if a parent says, I'm concerned, and the technologist is able to answer their question, everything's fine. And technologists are wonderful. They're wonderful people because they can answer these questions. But in the case that sometimes they're just freaked out, and parents can get that way, especially in pediatric imaging, I just tell them to hand my card. And then they call me. And so I get to talk. I actually just talked to a mother a couple of days ago because she was so worried because her daughter has had, I think, something like 20 x-rays. And over the course of this little girl's life, she's needed those for her medical care. But, when I explained to her that, a single chest radiograph is just less than a day's worth of natural radiation, she's like, really? That's it? I'm like, yeah, that's it. We're not asking for a lot here. We're just asking just for a little bit of radiation so our radiologist can make sure everything's okay with your kid. Yeah. So the answer is I would write something up, have that available. You can either put it in like your waiting room. So when everyone's waiting to go in, there'll be a little sign on the wall that says, information about whatever, shielding or radiation. Yeah. And then they can just take it if they want. Or you have it in the room. So if they ask a question, you can say, here you go, read this. 9 times out of 10, if they have a question and you answer it and they still are worried, even if we give them papers and we give them my business card, they'll go home and they'll never call. It's because at the moment they were worried. But once they left, the stress of being in the hospital went away. They realized, okay, I'm okay. Wherever they went to the hospital, they left, they got maybe medicine, they got treated. And so their concerns went away. And so we just have to deal with the stress in the moment. So information's good, but probably the best tool is a good technologist or radiologist, because sometimes radiologists get called in to talk to them, but a good way to just talk to them and help them calm their nerves and help them understand that what's going to happen, this procedure, this exam is for these reasons, and it's a good thing to help us understand how to help you. And when patients and parents and kids and whatever hear that, most of the time they calm down and you're okay. So learn to verbally communicate.
Mm-hmm.
And if that doesn't work, also have something to physically hand out.
Like a to-go person that they can contact and get all information. Mm-hmm. Yes.
Yep.
Sounds good to me. So come to the last question. I think like you may already answer this one already. So how about using a lead apron in the conventional radiology?
So a lead apron for a patient. So when I was talking about a couple of things going on here. So there's the lead apron that we place on our patient, the gonadal shielding or the out of field of view. Usually we place it on the lap apron or the pelvic apron. Those aprons really don't really do much. As long as the radiation beam, the light field, the radiation beam is not striking where the shield is, the shield is not stopping radiation. But here you see in this image, you see this dad back here, or I assume he's a dad, and this mom back here. They're wearing these lead aprons, thyroid shield, lead apron, it's a half body, typical lead apron that you and I as a staff member wear. And you can see this mom, she's standing here next to her daughter, probably there for moral support to help her. Okay, stand still, hold still, take a deep breath. She's probably there helping the technologist to get a good image. You see where she's standing, she's probably about 25 centimeters away from this girl. And so based on the research that we've done, I would say that she does not need to wear that. Now, if she asks to wear that, of course I would let her wear that. But technically, I don't think she needs to wear it. Just the amount of photons bouncing off this little girl and hitting her are really, really, really low. Remember, we're talking less than 0.3% of these photons that go into this child for imaging. Less than a percent of those are coming out and striking mom standing next to her. So is it hurting anything? No, it's not. So if mom wants it, go ahead, let her wear it. But in most cases, then, especially during COVID, you're going to have to sanitize that lead apron. You're going to have to put it away. And so obviously it's a cost. You have to pay for all of those. And here in the US, every year we have to survey. We actually have to we have to take every one of our lead aprons and run them under our fluoroscope to make sure there's no cracks or holes in them. It's required by law. And we have literally thousands of lead aprons. It's the worst job in the world to have to track them all down, review them, tag them, and do it again next year. So, if we could get away from using those, I wouldn't lose any sleep.
But for the interventional radiology, we need to wear an apron for sure. That is a different story.
100%. Yes, please. I just want to say once again, I'm talking DR in this example right here, DRCR imaging. If you are in fluoroscopy, general fluoroscopy, you're in the emergency room with C-arms, portable C-arms, you're in the interventional suite, cath lab, if you are standing at the side of the patient at the table, you should have your lead on because you are being exposed every day to radiation. And we don't need you to have any issues. So as a staff member, yes, in those cases.
Wow. There is a lot of questions coming right now.
Yeah, sure.
Yeah. So one thing, how do you think about the collimator braid effectiveness, especially for the high kV technique?
Yeah.
And another question is about the bone marrow shielding. Is there any bone marrow shielding?
Great question. So I'll answer the first one. Those collimators. So when you see this light field right here, every machine, when you look at the light field, the way the light comes out of these machines, it tells you exactly where the radiation is going to be. The system is not allowed to have radiation come outside of that light field. So anywhere outside of that light field, you're allowed technically up to 2% of the distance, the source to image distance. In other words, if you're 100 centimeters away, you would be allowed a couple of millimeters over. So we're talking just an itty bitty tiny bit that could come off. In my practical experience, having tested these machines for my career, where you see the light is where you get the radiation. There may be just a little bit that'll come out on the sides of it, but it's very, very, very small. And so one of the things I do as a medical physicist is I'm always double checking that the radiation, it matches the light field. And so that's because for two reasons. One, the technologist needs to know if they center the light field, then when they pull the trigger, the anatomy is going to be there. You know, if the light field is not centered, if it's mispositioned, then you'd get clipping in the image. And then the radiologist would go, and they'd have to reshoot the image. But the collimator blades are very, very good, especially at high. You know, if 125 kV, you'll probably never go higher than that. But at 125 kV and down, it's stopping 99% of all the photons. More than that, there is where there is no light, there are no X-rays. Now, there could be a little bit of scatter and a little bit of photons coming off, but that's happening all the way up here. It's happening high off the patient. And so those photons almost always just go scattering off into the room, and they're really, really small amounts. So going to the second question about what can we do about bone marrow? There's really nothing we can do about bone marrow. Bone marrow, of course, is distributed through our body. So that's actually the saving grace. As we age, it changes position. So little kids have a lot in their skull, for example, and that's why risk might be a little higher for doing lots of head imaging versus, arms. But then as we get older, it shifts into our spine and our pelvis, and it just changes location. And we just have to be understanding of that, right? Depending on the age, where the bone marrow distribution is, we can try to adjust our doses appropriately. And so I'm always very conscious about keeping doses low to our really little kid head CT scans, just because that's where most of their bone marrow is. But no, there is nothing we can do to shield about it. So we shield by using good techniques. And I would say one comment about the collimators. There have been many a times where I've been in and I get a phone call and the technologist says the mom will not let us do an X-ray. And I'm like, okay, let me talk to her. And she's like, I want my kid covered in lead. They quite literally want them head to toe covered in lead because they are afraid of radiation. And I simply explain to them, say, you know what? We actually put all of the shielding in our machine, so we don't have to wear. And then we walk in and we turn the light on, and I explain that to them. I says, see that where that light is? That's where the radiation is going to be. And that is what we need to make an image. And we're not going to use any more. But and then I point to outside of the light field and I say, you see how there's no light here? There will not be any radiation here. So we could place a piece of lead here or, an apron here, but it's not necessary. And I've actually done that many times. And most of the time the parent goes, really? Oh, okay. I didn't know the shielding was in the machine. And so explaining collimators and explaining lights actually is a very good way to explain to them why we don't need to be afraid of radiation going all over the patient.
Wow. That's good. Thank you so much, Sam, for explanation on the shielding in radiography and also some CT. So we can move to the next topic that we're supposed to talk today. Is about the mammogram metric and also optimization.
All right. We're almost done for the day. We haven't even started. All right, let's see. Okay, you should see my screens now. Good. All right, mammography. So we're going to talk today about image quality metrics and how to optimize them for mammography. So image quality today. Next week, dose in mammography. Now you're going to hear me say dose a couple of times, I'm sure, because as we all know, dose and image quality are linked. Excuse me. So mammography, why do we even, what's so special about mammography? Excuse me, got the hiccups all of a sudden. It is one of 3 imaging techniques that we use as a screening tool. Obviously, dental is the other one. We go in for get our dental x-rays every year. And more recently, we started doing CT scan screening for lung cancer. But mammography and dental are the most common. And pretty much everyone gets, especially women after a certain age. Now, when we look at the reason why we screen for mammography is breast cancer, of course. And so I looked up the statistics. These numbers come from the WHO, the World Health Organization. Among Thai women breast cancer is the #1 killer. There are roughly 22,000 new cases a year in Thailand and approximately 8,300 deaths a year. And so when you look at a breakdown, so this is talking only women, and this is 2020, so this is really recent data, you can see the biggest chunk of cancers for women is breast. Now, why is that a good thing? Because breast cancer is largely curable if we can detect it early. Now, you could say that about any cancer. If we can detect most cancers early, we can almost always cure it. But breast cancer, if we can catch it early, we can cure it. And that is why we screen with mammography, or with mammography, excuse me. Okay, the problem is, what are we looking for in mammography? There are some very specific things we need to see. Therefore, these are the image quality metrics that we need to optimize. The first is spatial resolution. We need to be able to see microcalcifications, which are usually early markers of disease that will eventually turn into a palpable disease, or a mass. So microcalcs are very important, and these things are teeny. We need to be able to visualize something that's about 0.15 millimeters. 150 microns is tiny. We also need to be able to see low contrast noise resolution. We need to be able to visualize the tumor itself. The problem is the tumor is made of the same material, the glandular material of obviously of the ducts, the glandular, and then all of the supporting structures, the vessels and the ligaments and all that stuff. The difference in contrast between the tumor itself and what we see in the breast they're very, very low contrast. In other words, they're very similar. So we need to be able to visualize the tumor, and we need to visualize the architectural distortions that come with just looking at the breast structure itself. We need to be able to do this in a variety of ways, both for 2D full field digital mammography, so 2D, craniocaudal and medial lateral obliques, so MLOs, and with our newer technology within the last 5 to 10 years, tomosynthesis, so we're kind of the quote-unquote 3-dimensional breast imaging. So the ultimate goal of screening mammography is to visualize something before it's palpable. Because once a woman can start to recognize, and I know there are other signs from, like nipple discharge, bleeding, and all that other stuff. So I know there are other things besides just a simple palpable mass, but the point here is once it gets to palpable, it's a pretty good size mass we're dealing with. So we need to see something small in a radiograph, in a mammogram. And all of these things we've talked about are actually, and that's the problem, is they're conflicting. We need to see teeny, tiny microcalcs, but we also need to see something that, as you can see here, that is of low contrast, even though in more diffuse, less edge enhanced objects, be they, architectural distortions or a mass itself. And so because of this inherent conflict of needing to see the microcalcs, this high resolution, and the low contrast mass and architectural distortions, we have to be able to balance what we can do with good MA and good resolution. So we're going to talk about that. So that was just trying to set up the need to discuss this. So let's start talking a little bit about the low contrast visualization. So in the US, they have the ACR, one of our societies for radiology. They've worked on establishing what are called the BIRADs, or they basically give you kind of a way to define how you visualize the image. And so, for example, diagnostically speaking, you can go from like a BIRAD 1, which is mostly fatty, to a 4, which is glandular fibrotic. Obviously, you can go like 5, 6, and I think up to 8. I can definitely know up to 6. But the point is you have the breast that doesn't always, one female breast to the next is different. And then one woman's breast over time is different. And so we have these different classifications. We call them here in the US BIRADs. I don't know if you use the same ones in Thailand or something similar. But the issue here is when you look at basically the material that we're imaging, which is glandular tissue. You have, of course, the ligaments and the vessels, which are going to be relatively high attenuating. That's why they appear white in the image. And then predominantly fat, which is going to appear more gray. Now, I know, of course, in the MLOs, you're going to get some muscle up here. But for the most part, what we're dealing with here are these fats and these glandular tissues. Now, you can distinguish the difference between fat and glandular tissue very easy at any stage, any BI-RAD ranking of any of these breasts. And that's because you look at the attenuation profile, fat attenuates less radiation versus glandular, hence glandular is wider. Now, that is true for basically all energies that we're imaging with. Down here is the mammo range, up here is the CT range, and anything in between, basically from about 50-ish over here, well, 40-ish over here, this is your DR or X-ray. So fat can always be visualized in both of these, in all energy ranges. That's not an issue. But when you look at glandular tissue, as an example, compared to infiltrating ductal carcinoma, the mass that you got to somehow find in all of this, down here in the CT range and in the general X-ray range, there is basically no contrast difference. They attenuate photons the same. The only time that these two start to separate are down at the really low energies. That is why we must image with low kV in mammography, is because of this very, very subtle difference in glandular tissue versus the actual mass or disease. So we'll talk a little bit about imaging down here in a moment when we actually start talking about the beam spectrum. So let's talk now about the high spatial resolution. So obviously we're doing this primarily to see the microcalcifications. This requires high X-ray energies. So right here is the conflict, and it also requires a very, very small focal spot, which only allows for low MA. So if you have low MA and high kV, that's actually the complete opposite of what you want with contrast. In this case, you want low kV and high MA, so you have no noise. And so what we need to do is we need to balance this, because we cannot have high dose in mammography if it's going to be a screening tool. Because if you're going to ask a woman to come in, but she turns 40 every year, or maybe every other year if their risk factors are real low up to a certain point, then you can't be exposing her breast tissue to very high doses. So looking at the machine, let's talk about the various different functions or factors in this machine that we need to optimize to get good spatial resolution and good low contrast, but do it in a way to have low dose. So completely conflicting, as I hope I just established. We're going to talk about the X-ray tube and the filters, compression paddle, and the grid. So the things here listed in blue are really what we're going to focus on today. Of course, everything else is part of this. Now, you see here, I didn't actually highlight the AEC or the machine, the part of the ion chamber down here that controls the amount of photons that come out. Obviously, that's the most basic thing. If that system isn't working, you're not going to get radiation out, and you're not going to get the right radiation. So what I really want to do is talk about some of the more subtle things that I know you guys have all got your AEC systems up. I mean, that's just a standard process. Every mammogram has an AEC. Now, you may use a fixed technique, so therefore you have your charts. However you approach it, you've set up the right MA and KV combinations. That I'm using as my basic assumption for this talk. What I think will be interesting is when you look at all of these options to optimize, the compression paddle, I think, is the one that gives us the biggest variability to image quality. So we'll talk a bit about that one. So starting in the X-ray tube, starting at the top down, the cathode. This is where all the magic happens to begin with. Here you can see the cathode with the large filament. So this is the large focal spot, and this is the small filament with the small focal spot. Typically speaking, we have two focal spots in mammography, and we need this because we're going to image the breast in two locations. One, in what we call contact. So the breast is on the contact images. The breast is down here directly in contact with the detector Bucky system. So the grid, the detector, breast is down here. In a moment, we'll talk about magnification, which I know are all aware of. You'll place a stand here and actually image the breast higher up, so closer to the X-ray tube. When we image under conditions of contact, therefore the source to the image source to the breast tissue is farther away, we have to use higher MA. Because remember, inverse law says as photons go from the source down to the detector, it changes by 1 over the distance squared. So you're reducing the amount of photons coming out as a function of distance. The problem with that is if we use really high MA, we have to use large focal spots. In fact, I'll just hop down to here. Typically in X-ray, so DRCR, we use a small focal spot of 0.6 and a large focal spot of 1.2. The reason for this is because we have to use lots of MA to penetrate large parts of our body. So chest, abdomen, pelvis, obviously. And then if you're doing, chest radiographs or you're doing a scoli, the X-ray tube and the patient are very far apart compared to maybe doing imaging on the body, on the table. So you need high MA to do this. You cannot do a high MA on a small focal spot. You'll just burn this filament out, it'll break. So in mammography, to keep the MA low so that we can use a very, very small focal spot, we keep the MA low so we can use a very small focal spot. So why do we use very small focal spots? It's so that we can get good resolution. The smaller the focal spot, the smaller the object we can see. Now, the problem with that is we still need to penetrate the breast tissue. Now, we're going to talk about how we're going to make that smaller by compression, but we still have to penetrate a certain amount of breast tissue. So therefore, we need enough MA or enough photons to get through. If we are limited on how high we can turn the MA, when you look at the equation, MA times time, so the mass, the only thing you can do is leave the machine on longer. So mammography, of all the imaging modalities, is probably the one that is most susceptible to patient motion. And that's because with the large focal spot, so breast in contact to the detector, we're turning on the machine for probably 1 to 2 seconds. So if the lady just moves just a little bit or whatever happens, you can see here, this image has motion blur in it. So everything has just got a blurry look to it, no crisp edges. Same patient, same view. They simply just redid the image and you can see how much more crisp it is. All these little microcalcs, you can visualize some of the ligaments, the stranding, or the vessels, the vasculature, you can see it. Obviously, the glandular tissue is a little more crisp. And the other thing is when we go to magnification view, remember magnification view has very low MA output. We typically only do about 25 MA, whereas contact is about 100 MA. And because of that, for mag views, we almost always have to image for up to 3 seconds. So we have a lot more potential for motion in a magnification view. So looking at the orientation of the X-ray tube, the focal spot itself is set at an angle to the detector. And we do this is called the line focus principle. We talked already about this in X-ray. You remember the heel effect, all of that stuff. We've already talked about this when we talked about a couple of weeks ago. But the thing about this is it gives us the ability to have a larger focal. Actually, I meant to say, basically what I'm trying to say here is you can have a relatively large focal spot here, but you have a smaller effective focal spot down here. Let me try to say that better. Because of the angle of the target, the electrons as they strike at that focal spot gets actually spread out a little bit. So heat-wise on the tube, the heat gets distributed more, so you can use a little bit more MA. But because of the way it comes down and it diverges, it actually projects a smaller focal spot on the detector than it is on the target or the anode. I go into a lot more detail several slides ago or several talks ago, so please go back to that. But the point of this line focus principle, it gives us the opportunity to give us really good spatial resolution for mammography, and it's mostly based on the nipple side. So resolution is best at the anode side, which corresponds to the nipple side for imaging. You really won't notice this better resolution difference in contact imaging, but when you're magged up, and let's say you're magging and you're actually doing more of you're imaging more towards the nipple side or the anterior side, then what's happening here is you will actually notice the spatial resolution is a little bit better there. Okay, so the other thing here is the tube is tilted so that we can have a larger field of view. If this tube was flat, then your field of view would be limited. You wouldn't be able to get all the way out to 25 to 30 centimeters. And what we want to do is we want to image as much of the breast as possible. So for small breasts, that's not an issue. But for relatively large breasts, then if they don't fit on the field of view, of course, you'd have to do 2 images. So you're just doubling the dose of the breast. So having a larger field of view is good because you can get all the anatomy in one shot. But it's also especially important when you're doing the medial lateral oblique or the MLO view. So now, as you're imaging this way, you're going to get up into the axilla, and you need to be able to image up here to visualize, the axilla tail to get some of the lymph nodes. But the upper outer quadrant of the breast, I know you all know this, but the upper outer quadrant of the breast is where we find a lot of breast cancer. And so getting a larger field of view, especially in the medial lateral oblique view, is very, very important. So you can image what is probably one of the more important or sensitive areas of the tissue. So let's look at the concept of how is the resolution limited? So in contact mammo, which is majority of what we do in full field digital mammography, the resolution is limited by the focal spot size. So when you have a 0.3 millimeter focal spot, you will just have a limit to what the smallest object you can see in the detector. Now you bring the breast up in a mag mode, because remember, you get magnification. The farther away from the detector you get, the bigger the object appears in the reconstructed image. So as you do that, as you put the breast higher, you're geometrically magnifying the image. Now the limitation, the spatial resolution limitation is not the focal spot anymore, it's the detector. So this is where you need to have a really good, high quality detector, really finely spaced dexels or DELs, the digital pixel values. Okay, so that's the cathode. Let's move over to the target, the anode. Historically, these were made out of one of 2 target materials. First would be molybdenum, and the other may have been rhodium. So we had your moly and your rhodium as your 2 options for targets. This was predominantly done during the screen film era. There is one vendor still on the market, GE. It's probably not a surprise for those of you that know that, but there's one vendor on the market that still uses the moly-rho targets toward the anode. There is a lot of benefits to this. The molybdenum have K-edge, and the molybdenum and the rhodium have K-edge values in the energy range that we are using for mammography. So that gives us the opportunity to really focus our imaging to get really good monoenergetic photons in the area, in the range which we're doing our imaging in, so that we get good high contrast. This was very important, especially in the film era, because film, the contrast was based on your technique. If you overexposed or underexposed, you lost your technique. You lost your contrast, excuse me. In digital imaging, if you under or overexposed, as we talked about a couple weeks ago, you can actually manipulate the image. You can change the latitude on your post-processing, and you can actually recover most of that contrast. So you can make it look okay. And for that reason, most digital systems nowadays have moved to using a tungsten target or an anode. Tungsten, of course, has a much higher melting point, so you can use higher MA or MA on longer, so you have less potential for damage. But the problem with that is there are no K edges. I mean, there is a K edge for tungsten at 69.5 keV, so that's way outside of the range of mammography. We use that in radiography when we're imaging up in the, obviously, up in this range. They do have L edge, which we'll talk about in a moment, but that's down in the 10 keV, and 10 keV is too low, and I'll explain in a second. But because of the digital systems, the dynamic range of the digital systems, we can actually get away with using tungsten a lot more. So tungsten gives us a larger Bremsstrahlung spectrum. You can kind of see these spectrums here. These are all tungsten spectrums with different filters, rhodium, silver, aluminum. And that gives us the ability to image a good wide spectrum within that 10 to 30 keV. 20 is kind of the sweet spot. That's why you see these are all basically centered over the 20. I mentioned these L shells for tungsten. Anything less than 10 keV, and we'll talk about this next week in dose, when we talk dose optimization, all of this is just skin dose. A 10 keV photon will absorb on your skin. It will not penetrate. And so it will not go through the breast. So we want to get rid of all those. And in every case, tungsten can be paired with various different filters, such as rhodium or silver or aluminum, and it gets rid of all these L shells, and it gets rid of these high keV, these high energy photons up here that would decrease our contrast. So pretty much all scanners nowadays are moving towards tungsten. They are usually typically using a tungsten rhodium combination, although you can, like I said, say tungsten silver or tungsten aluminum. But when you look at, say, tungsten rhodium as a combination of target and filter, we are seeing glandular doses that have been reduced by about 50%. But the noise signal to noise ratio, the SNR, stays basically the same compared to our old film days when we use moly-moly, moly-rho, or rho-rho. And then we'll talk about breast tomosynthesis a little bit later, but basically we need, because we're now doing a sweep, an arc, and imaging multiple different angles, the tube is on longer. We absolutely need a target such as tungsten that has a higher melting point so we have less damage. Okay, so real quickly, when you look at the Bremsstrahlung spectrum that we use this is a generic one that we use in mammography, everything that's real low, less than basically 15, is going to give you skin dose. We want to get rid of that. And everything above 20-ish, above 22, 23, all of that is basically going to cause you to lose contrast. So what we're going to try to do is we're going to try to image right here in the dead center. All of our systems will have a beryllium exit port. So all X-ray tubes, they're made with glass envelope, but the place where the photons come out, because the glass would absorb almost all of these low energy photons, they actually have to use a little beryllium window. And now beryllium will add a little bit of attenuation, but not a lot. It gets rid of the basically 5 and under keV. So we have to do some kind of anode paired with a filter. For those of you that still have film-based systems, well, then you're going to have a moly target. You're going to have one of two options. You're going to have a moly or a rho target, a molybdenum or a rhodium target. And that is because we want these K-edge values, these characteristic X-rays. These really strong characteristic X-rays provide really good imaging that gives really good contrast. And that is the whole reason why we did that in film, as I already explained. Depending on the thickness of the breast, depends on the KV selection option you'd use with the moly target. And it depends if you would use a moly target with a moly filter. So if it's thin, fatty breast or a little bit thicker glandular breast. Now, if you use the moly target with a rho filter, you're doing this for the much denser breasts. And that's just because the rhodium, it's just because you're going to basically keep a little bit more of these higher energy photons to penetrate the thicker breast. So a moly-moly combination or a moly-rho combination will just really get rid of most of this right here. But if you did a molly combination, gets rid of this right here. A molly row leaves a little bit of that behind. So that you actually had to pay attention to the breast thickness back in the screen film days. A row is the same thing. It's shifted a little bit more to the right, and we use these for real thick breasts. And we would never, ever, ever use a row target with a molly filter, because if you had a molly filter on a row target, it's going to get rid of the characteristic x-rays of the row target. And that's just because the characteristic x-rays of molybdenum is lower than rhodium. And so we never, ever want to do that. So molly, row, yes. Row, yes. But never row, mo. Never row, mo. Now with tungsten, we will pair it with any one of these, but specifically looking at aluminum. Aluminum gets rid of the L edge down here, so that's good, gets rid of the skin dose. It also removes some of the higher energy stuff up here, but it does keep, the aluminum is actually the widest spectrum here. And this broader spectrum is actually good for digital systems, because you get good, the digital systems will take care of the contrast, the loss of contrast for including these higher KVs, but it gives you more flexibility to image thinner or thicker breasts. You don't have to worry about changing different filter options as much if you're using a tungsten aluminum combination, because you have these higher photons here for denser breasts. Now, you will get penalized if you have a really thin breast or a fatty breast, but that penalty is largely overcome by using the digital system that will correct for that contrast. So talking a little bit about the type of filter you use, going back in time, as we talked about this a couple of weeks ago, we talked about the half value layer, which defines the beam quality of the photons coming out of the X-ray tube. And so when you look at these various different combinations, so here's tungsten, aluminum, here, you can see you have a relatively high beam quality. Tungsten gold, tungsten rhodium, tungsten aluminum. These have higher quality, so they have better penetration through the breast without scattering, so that you get photons in and photons out and incident on the detector. So that gives you really, really good contrast. Now you go down here at the low KVs with, say, the molly, you actually had a lower quality, less penetrating. And that's why molly could only be used with the least dense or the fatty or the thin breasts. So you actually just had to pay attention to that. Once you get to these tungsten anodes with all the various different targets, you really don't have to think too much about the type of breast you have. And then, of course, always remember that the paddle itself, the compression paddle, adds some amount of filters. So let's talk about how these filters how we use that to optimize our output. So we're talking about a half value layer of breast tissue of about 1 to 3 centimeters. So approximately every 1 to 3 centimeters, 50% of the photons will attenuate. You go another 1 to 3 centimeters, 50% of those will attenuate. So you go 100% as it enters the breast, 50%, a quarter, et cetera, et cetera, et cetera, et cetera, an eighth, a 16th. And so by the time you go out of the breast, you have very little photons left. So if we talk a little bit hypothetical here, well, I'm sorry, we'll do a hypothetical example, but this is why we use compression, because there are a lot of benefits to compression, which we'll talk about in a second, but the biggest one is you're going to take a breast tissue, whatever thickness it is, and you're going to reduce it. So you're effectively reducing the number of half value layers there is to penetrate. So when imaging with, say, a 20 keV beam, you have roughly a half value layer of 15 millimeters, so 1.5 centimeters. The number of photons will decrease by 1/2 every 15 millimeters. Compressing the breast reduces the number of half value layers. I just said that. So here's the example. So if you have a typical 4.5 centimeter compressed breast, then 1 in 8 photons will make it through to the detector down here. If you aren't as good at compressing that, you're just not able to fully compress it, so now the breast is actually 6 centimeters thick, then only 1 in 16 photons will arrive. So you can see here how the compression paddle will actually dictate how many photons will get through, and therefore dictate the overall actually dose to the breast, because you have thicker breasts have to get more photons, so therefore it's going to be a higher skin dose, but it'll also dictate the image quality. So compression paddles decrease tissue thickness. For one, it does help reduce the dose of the patient, which we'll talk about more next week. But two, it also helps reduce scatter. The amount, if you have less breast tissue in this field, in this axis, then you're going to get less scatter. So this reduces your scatter fraction. Ultimately, mammography is actually not limited by noise. It's actually one of the least noisy imaging modalities we have. And if you ever have a mammogram, you expose it and you look at it and it's very noisy, something has horribly gone wrong, because most mammograms are not noisy because we can compress it and the system will then be able to compensate and get the right amount of photons through. So if the image looks really noisy, typically one of two things have happened. One, the compression paddle has failed to get you the right compression force or pressure. Or two, you may, if it's contact breast, you may have actually taken out the grid and not put it back in. And so the system has not given you enough photons. All right, so let's move on to breast compression since we're here. Breast compression has many benefits to optimize image quality. One, it reduces motion. Literally, it's holding the woman in place. Two, it lessens the geometric blur. So I'll talk about that in a minute. The closer an object is to the detector, the less blur you have on the edge of an object. So less blur in the image. It reduces the overlapping anatomy. So if you have dense breasts or lots of glandular material, if you're spreading it out, and so you're spreading it out laterally, you're just going to have less material that you have to read through. And then, of course, it makes it more uniform. And so when you actually compress the breast, you have a more uniform field of view to look at instead of a very dense part, maybe at the dead center, because it's not compressed completely. This will lessen the dynamic range, so it's really good for post-processing. It's good on the computers, but it also will help the radiologist get the symmetry they need. I mean, when you do a two view, you got the craniocaudal left, right. If one's not compressed the same, you're going to get that asymmetry in the actual look of the breast, and the same with the MLO look. So when you look at asymmetry issues, so you actually have two breasts showed side by side, only about 3% of the time that the asymmetry you see is pathologic. Is based on pathology, is based on disease. In other words, most of the time you see asymmetry, it's actually due to compression failure. So optimizing the compression paddle helps us make sure we get good image quality. So here's an example. This is asymmetry due to disease, looking left to right, and the CC, and then the MLO. This is asymmetry due to compression. Here, left to right here. All right. More and more frequently, we're dealing with women with implants. So we have to do our absolute best to get the implant out of the field of view. Now, I know you can't always just budge it out of the way or push out of the way like you're seeing here. In a perfect world, we would just retract the implant and image the breast tissue. Can't do that. Why are implants not good? Well, why are they detrimental? How are they not good for image quality? So when you image the implant, obviously it's going to change the dynamic range of the grayscale. Obviously, this is a fluid filled, silicone, whatever. But the point here is it's going to attenuate a lot of photons. And so this is very white. And it's going to change that dynamic range so there's less grayscale here in the breast. So in this case, where the same patient, in one here they imaged with the implant in place, and the other one they were able to largely get the implant out of the view. And you can see here how the glandular and fatty contrast is much greater in this view than this one. So optimizing the actual placement of the implant is good, and optimizing the compression. Obviously, you'll get better compression if the implant is just out of the way. Implants, of course, are less compressible. All right, we need to talk a little bit about this compression. So compression force. This is the standard by which we measure how the paddle will compress the breast. Typically, we're aiming for about 111 to 200 newtons, or as it's often shown on the scanner, 11 to 20 decanewtons. If you're here in the US or over in England, it's going to say something like 25 to 44 pounds. We know that and so what you're aiming for, depending on how you've been trained, is you're just basically going to put the breast in there and you're aiming to get a force somewhere in this range. We obviously know we don't need as much for breast tomosynthesis, and we definitely, it's a little bit different when we do the magnification or spot film compression. So more recent research in this area has looked at, I told you, the variability. If you look at image quality, it's my opinion and others in our field that most of the variability for the image quality is coming due to inconsistency of compression. And that's because we've largely used we've only used one metric, which is force. So we're talking about, the decanewtons. But what if we talk about pressure instead? So pressure is force per area. So now it takes into account how much of the breast it's compressing, how much of it's pressing onto the breast. So the use of force is inconsistent across practices of mammography. Using pressure considers the area of the breast where the force is applied, which also takes into account the breast shape, the elasticity or compressibility of the breast, and overall its breast density. So we know smaller, younger breasts tend to be more dense, and then, of course, older, fattier breasts. So in this publication that came out a couple of years ago, it's about 5 years old, it's a really interesting publication. What they basically did is they looked at, it was a retrospective study, they looked at almost 40,000 breast images. And what they did is they went in and they looked at the DICOM metadata, and they looked at the compression force and the compression pressure of all of these, and then they simply did a scatter plot to look at basically what is the force as a function of contact area, or what is the pressure as a function of contact area. So here's the DICOM tags. I simply did a screen capture for you. So if you ever pull up your mammogram and you're looking at it on a PAC system or whatever reader you're looking at, if you look at the DICOM data for that image, if you go to tag 0018, 11A2 or A3, the system, if it maps it, will tell you what the compression force is and the compression pressure. So you could technically do this exact same thing. You could look at what the distribution is in your institution or for everyone in Thailand. And this study was comparing the Netherlands versus the US. And what you see here largely, what you largely see here is as force goes down, so using less force, it's actually because it also correlates with a smaller area of the breast being compressed. And what the biggest problem with all of this is, and so the way we've been doing it when we look at the use of force as a metric, well, what that means is when you see the pressure, it's actually going super, super high for these really small breasts. And so this is where you're probably getting a lot of pain up in this region. But over here, you're getting a lot less compression. And so you might actually have a lot more, you have poorer image quality down here on this spectrum. So the results of this publication, they looked at the average force was 14 decanewtons. So between 11 and 20, so that's great, right? In the Netherlands, it was actually 7 decanewtons in the US. And so here in the US, we were not compressing nearly as much. The average pressure was 14 kilopascals, and in the US it was 8 kilopascals. So the trend was lower force to smaller contact area, which I mentioned, and the force is adjusted based on the mammographer's sensitivity to patient's pain, not to the breast size or elasticity. And so you can see here in the US, they're not using as high a force, largely because as the authors surmised in their publication, was you have a woman come in, they go down, they start to compress, maybe the woman starts to verbally say it hurts or winces, so their face just has that kind of a look of pain. And so the mammographer doesn't compress any farther. Whereas I guess in Europe, they keep going no matter what pain tolerance the woman has. And so why is this an issue? And what are they proposing? And where are we kind of starting to look to change this idea? If you go in and you try to maintain a constant pressure, which you'll see here in this purple band or red band here, what that means is you have a target in your mind as a mammographer. You got the woman, irrespective of the breast size, thickness, elasticity, etc. You got her on, and you're starting to compress. You're trying to get, let's say, 14 decanewtons. And if you do that, well, for the little breasts, so contact area, you got small breasts over here, same force, smaller area, you're going to have low pressure. But as you hold that force the same, as the contact area gets bigger and bigger and bigger and bigger, pressure is just going to go through the roof. And it's going to equate to a lot of pain. So it results in high pressure for small contact area. Okay, no, I said that backwards. My apology. I said that backwards. The pressure will change linearly. So as the force, if you hold the force the same for a small area, my apologies, the pressure goes really, really, really high. And that's where you get a lot of pain in the patients. And then as the force is held constant, what happens is the pressure goes down. And so you get less compression over here and potentially more image quality issues. So what they're suggesting is instead of a constant red line here, constant force, they're saying change the force as a function of breast size so that the pressure will be constant across all breast contact areas. So for small breasts, same pressure as large breasts. But what you have to do is you have to change the amount of force being applied to get that. So that's just going forward. What you really need to do is kind of look at how you calibrate your force. You need your force sensor so you can calibrate the compression paddle, and standardizing as best you can the way you actually apply that compression so that you get equal compression, so more uniform imaging across all breast sizes. All right, just briefly talking about the anti-scatter grids, we know, so we're just moving down the chain here. The grids are very important because they reduce the amount of scatter. So photons come in, they interact in the breast, they cause scatter. We use the grids to clean that up. Decreasing the amount of scatter increases or improves signal to noise ratio. Using grids, we only use them in contact mammography only. We do not use them in magnification mode. And they allow roughly 60 to 70% of the primary photons to go through the breast and through the grid to the detector, but they're really efficient at absorbing 75 to 85% of all the scatter radiation. So in contact mode, you should always, always, always image with a grid in. Now, when we do magnification mode, now what we've done is we've placed a little magnification platform on. The breast is a little higher with respect to the tube to the detector. This gives us the ability to image so it projects the anatomy larger on the field of view, so we get just a magnified view of the breast. You can see the typical magnification modes are 1.5, 1.8, or typically 2. So if you get that breast somewhere in between, source to object distance of about 35 centimeters versus the object source to detector distance, which is usually fixed at 65, so basically right in half, that's where you get a magnification of 2. Kind of makes sense. We went over this equation before. I simply give it to you again. So the benefits of magnification, of course, is it really takes a small object and it allows you to see it a little crisper and a little cleaner. Remember, in magnification mode, the limits of your resolution is this detector itself, not the focal spot. So you can now start to see 0.1, 0.15 millimeter objects, which is what we said was a mandatory requirement in mammography. All right, when you image in magnification mode, there's actually less noise, apparent noise in the image, because you have the same anatomy being shown bigger on the matrix or your detector. And so when you just look at the ratio of anatomy to noise, it's just larger. So these images will inherently look less noisy. And like I said, this is one of the reasons why mammography is actually a relatively low noise modality. Now, we take the grid out because we don't need a grid, because now there's space. We have this air gap right here. So photons come in, they interact with this breast, they're going to scatter. And a lot of those scattered x-rays will just scatter into the room. They will not in any way interact with the detector. And so remember, when we talked in fluoroscopy and even in, well, mostly in fluoroscopy, if you do geometric magnification, it increases the amount of photons. The system, it increases the dose of the patient, because the patient is literally closer to the x-ray tube. But if we take the grid out, we don't have to use as many MAs, we don't have to use as many photons to image the same thickness of breast. So the air gap reduces a scatter, and by removing the grid, it also reduces the amount of MA that we need, which also reduces the amount of scatter. So it kind of balances the scatter and noise in the image, and it reduces and balances the dose of the detector. So it's equivalent, but we'll talk dose next week. So what are the limitations of magnification? Well, we talked about this, of course, a while ago, but the closer an object is to the detector, the sharper or crisper the edges are. The farther away from the detector, because our focal spots are finite, they're not infinitely small, they're actually finite, we will get some of this geometric blurring, which causes the edges of our objects to be a little bit less sharp, less crisp. So that is an issue. You're going to get a little less sharp, a little less crisp objects. That says you'll be able to see much smaller objects, so it kind of somewhat balances itself a little bit. Obviously, motion's an issue, because if you're higher up and you're imaging for upwards of 3 seconds, there's greater chance for movement. Okay, so shifting into, so that was all 2D or full field digital mammography. So digital breast tomosynthesis, or DBT, enhances the contrast in the image, because now we're going to acquire a three-dimensional, quote unquote, three-dimensional view of the breast by sweeping the tube over the breast and acquiring a series somewhere, around 15 or so images. And then that'll allow us to create a stack of images. When they've done various different studies, and they've been looking at this for now almost 20 years, the sensitivity and specificity of the radiologists as they read mammograms increases in tomosynthesis or 3D imaging compared to the 2D full field digital mammography. Why is that? Well, I don't have to be a radiologist to tell you that there is something here. As you take an image, and as you image it across the sweep, you're then able to then reconstruct, basically kind of cut the breast in like a loaf of bread. So in a craniocaudal, it kind of cuts it, obviously craniocaudal and medial lateral the same way. So you have the stack. And so often, as radiologists do, they'll be looking at it in 2D mode. If they think they see something, they'll flip over to 3D mode and verify that it's there. Now, the beautiful thing about 3D mode is you actually have all the information for 2D. It's all there. We just have to reconstruct it. And so more and more common now are the synthetic two-dimensional view image. And each mammography vendor will call them different, like C-views or synth mammos. They're all different names, so don't get caught up on that. But all it is just taking the stack of images and projecting them into a two-dimensional image. Now, you cannot take a craniocaudal tomosynthesis and project that into a mediolateral. So in CT, you can acquire the image axially, and then you can create your reform at sagittal and coronal and axial and all that. But in tomo, if you want a synthetic MLO, you have to do a tomo sweep in the MLO. And the same thing for the craniocaudal. If you want a synthetic of the CC, it's got to be in that. So that is one thing to consider. The benefits of the synthetic is that it's been shown to be equally sensitive and have equal sensitivity and specificity as a traditional, true, acquired two-dimensional full-field digital mammography. Allows side-to-side breast comparison, whereof, of course, you can't really put these side by side. It's a stack. But traditionally, obviously, you do your CCs and your MLOs side by side. So that still gives you that a traditional way to view the breast. Gives you the ability to look and assess interval changes, visualize microcalcs. Microcalcs are not as well visualized in the tomosynthesis sweep because there is blurring that occurs. Blurring because A, the breast is hold still, but the tube is constantly moving when you're acquiring imaging. It's not image, stop, move, image, stop, move. It's not stop, step, and shoot. It's actually a constant movement. So there is going to be inherent blur. And two, the way they reconstruct it is they blur everything out of the plane of view. And so if you're imaging, if you're trying to look at a specific view in the breast, so like let's say mid-breast, everything outside of that, above and below, it's going to be still projected into this 2D image, but it's just out of focus. Microcalcs are so small that depending on how you reconstruct it, you just may completely miss it. So typically when we're looking at these microcalcs, they're best to be seen in 2D, either in the synth mode or, of course, the actual 2D FFDM. And then probably one of the best things about this is these synthetic 2D images are free. You acquire the tomo sweep, you can reconstruct into 2 dimensions. You don't actually have to acquire two series of imaging. What are some of the the things that you have to be aware of when it comes to image quality in a 2D synth image? First of all, is you're going to have artifacts. And here I'm going to show you a series of images on the left, which are the true two-dimensional full-field digital mammography, and then the others are the synthetic. Whenever you look at a synthetic, you're going to get these out of plane, or what they're called slinky artifacts. And so you have a really high contrast, high attenuate object that spans multiple slices of the tomo series. Well, when you combine them all, what happens is you actually lose some of that information out of plane. So obviously this black area, that is an artifact. That is not true anatomy. But that is, if I didn't tell you this is a synthetic image and you saw a high contrast object with these big telltale black stripes on both sides, you would know it's synthetic in a heartbeat. And these are going to show up where there's surgical clips, biopsy markers, dense calcification, etc. All right. Synth modes will at times not have really good, clean skin lines, and this has a lot to do with the fact, especially if you have a dense breast and you're doing a tomo sweep, you're going to have a relatively high MA, and it tends to burn out the anatomy when you do the reconstruction. Not physically burn it out, but when you reconstruct the image, because you have saturated the detector right here with high levels of photons, it tends to blur, it removes that information. Whereas in a 2D view, you don't need as much MA, so it doesn't, over time, so it doesn't actually cause you the degradation of the skin line. You'll also get these bandings in the synthetic, and that's just because you're taking a 3-dimensional object and you're averaging it together in multiple planes of view. So I would be remiss if I didn't say something about the viewing station. You've gone to all the trouble to get the right KV, the right filter, the right compression. You're optimizing your contrast, doing full field digital mammography, your tomosynthesis, and then you try to read this on a horrible monitor that's out of calibration. You're doing yourself no service. So once you have done your best to optimize the machine and the output and the reconstruction, you've got to absolutely have a good monitor. especially in mammography. In mammography, you have to have a high megapixel system, at least greater than 5, so that you can see the resolution that we're demanding for these microcalcs, etc. So you need to have at least a matrix size that's about 2,000 or so and 2,500 by 2,500. The pixel depth is the same. You can remember our eyes can only see so many grayscales. So 256 and 8-bit is fine. You want a physically large monitor. Everything we image with mammography is actually in mag mode because the image itself, the detector itself, will produce an image that is larger than 2,000 by 2,500 pixels. So when it's presented in 1-to-1 ratio, the breast is big. And so the bigger the monitor, the more of the anatomy you can see at one time. Inevitably, when we're actually looking at the full breast anatomy in the image, especially if you have multiple views, CC and MLO next to each other and multiple time points, you're actually looking at a highly zoomed in demagnified image. And so you want to be able to see all of these standard images like this. And that's actually an important thing. I want to just remind you this. We talked about this a while ago, but how can you optimize the contrast in a viewing situation? Obviously you need to have your lights right, but the closer you are to your monitor, the less your eye can see the contrast. And that's just because of the geometry of your retina. The closer you get, the more photons are, the smaller the area of the smaller your viewing area is. So you're only able to fixate a certain amount of photons or light coming out of the monitor from a small part of your monitor into your retina. But the farther back you go, the more pixel light coming out of your monitor will strike your retina itself. In other words, you can visualize more subtle low contrast the farther back you are. Now, I'm not advocating everyone stand 20 feet back when they're reading a mammogram. What I'm saying is when you look at a demagnified image, subtle low contrast findings will pop a little bit more to your eye. And, I don't know how every radiologist does it, but a lot of times if you pull up and you have like your MLO and your CC for one time point and maybe your MLO and your CC at the baseline, so you have basically so you have obviously 8 breaths and 4 2 time points and 4 views up. It's very small by way of detail, but the subtle changes and maybe architectural distortions or asymmetry will appear more to your eye. And so then you can do that as a quick survey, and then you kind of know, okay, maybe this is a region I'm going to focus on. So when you pull up the straight MLO or you look at just that breast itself, you can then interrogate that area more clearly. So the point here is image quality is great. Low contrast is important, but we can actually optimize image quality just on the way we look at our images. You need to standardize the mammo image quality. So I give you the example here in the US. We have a standard. It's called the MQSA. And it defines a minimum image quality that every system has to perform at. Every breast image acquired in every view, CCMLO, whatever, tomosynthesis sweep, has to meet a minimum standard. And we've been doing this basically since 1992. I don't know, admittedly, I don't know what the rules and laws are in Thailand. I assume you have something like this. I would hope that you have a general consistent standard, because this really helps make sure from view to view, time point to time point, especially in a screening modality, you're getting consistent image quality over time. And no matter where the individual goes, whatever hospital. Our MQSA actually goes beyond just saying image quality, setting image quality standards. It sets competencies. So radiologists, technologists, physicists, we have to meet a specific competency so that we can operate in the mammography space. And it, of course, sets minimum image quality, and it tells us how high the dose can be. And it should be no higher. Obviously, that's very important for screening mammography, which we'll talk about next week. So just in closing, we talked about how there are 2 competing image quality metrics we have to optimize in mammography: spatial resolution and CNR. and how they're competing. They're antagonistic. Spatial resolution wants high dose, wants low MA, so you can have a small focal spot, and high KV for good penetration. And that in itself will be bad for CNR. In CNR, we want low KV and relatively high MA, so we get good contrast, low noise. And we talked about how we can overcome that by using small focal spots, doing either contact or magnification, getting the right anode, mostly nowadays the right filter combination, and etc. So, yeah, that's what I just said. And then we need to develop a constant approach to compression. And that, I hope I shared enough insight to think that the compression is really a good way for us to keep the breast looking consistent from time to time, getting the anatomy all spread out and whatnot. And then, as I mentioned, we should standardize, if you have not already, come up with a standard national image quality standard so that every mammogram ever acquired in Thailand will meet a basic minimum so that we know the image quality is consistent for all of our patients. All right. Thank you.
Thank you so much, Sam. So I think in Thailand, we use the same approach compared to US, including a BIRADS and also like an image quality for the to test the machine, and also like we have like a dedicated mammo technologist.
Okay.
To do that part, and also physics, but I'm not sure about radiologists because I know in US you need to read a certain amount of number to be certified every year, but in Thailand I'm not sure on that part. But most of the people who doing mammogram usually just like a focus on mammogram. So because like this is like a very, I think it's like a very detail-oriented study that you need to train your eyes to see something like a very, very small stuff. For me, if you ask me right now to read mammogram, I'm not sure that I can do that to call microcalcifications. See that really well. Yeah.
No, it's very highly specialized, and so I completely agree with that.
So, and I remember on like the first couple slides in your talk, you talk about like molybdenum and rhodium, right? RH, right? And those things, I remember those things from the old days when I was a resident for that we need to take the exam on those things and also have value layer. But right now, I don't, I'm not sure that I remember those things. Yeah.
Yeah. So most of that, I mean, unless you're using a GE scanner, you don't have to worry about Molly and Rho anymore. Every scanner, the Siemens, the Philips, the Sectra, all of those, Hologic, they're all using tungsten now. And that's because, and I assume this is probably the same for Thailand, most institutions are moving towards tomos. Almost all systems are tomo capable.
Yes.
Now, does that mean everyone gets a tomo? Maybe not, but a lot of the time now, especially for baseline imaging, you're going to get a tomo and you're going to get your 4 views to, CCMLO for both breasts. And that becomes your standard. If you're low risk, then it might just be full field digital mammography going forward. But the point is having that ability to do all of that imaging, you need a tungsten scanner, a tungsten target. And when it comes to half value layer and it's making sure you set that all up right, if you've set the right KV, the system will get you the right beam quality. But if you don't get the right beam quality, then obviously the penetration is off, and so you will have a problem. And it's almost always manifest because you are limited with how many how much MA you can use. So almost always, if you don't have the right beam quality, you don't have the right compression, if you don't have the right KV, if you don't have all of that, it's time. The only thing it can do is leave the system on longer, and that induces more motion blur. And so usually if you see consistent motion blur in your mammograms, that's where you need to start going back. Okay, am I compressing properly? Do I have the right KV? Do I have all those other things? So the type of artifacts you see in mammogram will actually help you kind of troubleshoot what's going on in the image.
I see. Yeah. So come to the questions about the standard compression force. Should it be like a 25 to 40 pounds? How is the practical force in USA?
Yeah, so that's what they aim for in the US. And that's But what we're seeing more now is they're moving kind of away from this idea. That's this right here. So if you look at the red right here, and I screwed up when I made the mistake when I was explaining this, so I'm sorry. It's probably very confusing. If you have a consistent force, say 25 or 40, then what's going to happen is for your really little breasts where you have small area of pressure, but you're still pushing as hard, you can see here the curve goes really, really high. This pressure goes really high, and that's going to hurt. Whereas if it's on this side and you're still using the exact same 25 or pounds or whatever it is that you're using force wise, but it's a larger area because it's a larger breast, then it causes problems down here where you're not compressing it enough. And so the whole concept here is to move towards this idea of now the system will take into account the actual area of the pressure, the area of the breast, and the density of the breast, and it will apply different force for different people. And that's where you get different forces will give you the same pressure. In other words, the same compression. This is a work in progress. The systems are getting better at being able to do this, where it can make a general guess or estimate based on the area as it's pressing down and the overall glandularity or the elasticity of the breast. And that would then help. There's an algorithm in the system that would then be able to decide which force to use. So now, most mammogram systems or mammography units, the force is applied with the foot pedal. The mammographer gets the patient in, gets the breast situated, and they're starting to apply the pressure as they're moving their hand out. Just a typical situation. And they're pressing down based on obviously the number, but also based on what the patient is experiencing. And so the hope is that we can start to use more intelligent, the system can be more intelligent, and it can help them say, aim for this force. And that would be a way to help give them a target based on the patient's size and density. So like I said, it's kind of more of a work in progress. But I honestly see in the future, this is where we're going to be, where it's going to be more, instead of us thinking as much about force, it's going to be pressure, and it's going to be more consistent across different patient sizes.
You mean like an AI technique or something that integrate to the system that can adjust the force or like a compression stuff?
The answer is yes, that could be a part of it. Admittedly, this is a little bit early on in the implementation. A lot of the systems have a way of calculating. You can tell the system, general density and size. The mammographers know all of these when they're kind of setting the patient up and going forward. And so basically, by telling the system these things, the system would know. Oh, okay. Well, if it's a smaller breast, potentially more dense, then it would know to give a different target force. So as they then step on the pedal and the compression pedal comes down, it would then help give them feedback as to, okay, now you've got the right force, instead of going all the way down to you have 25 or even 40 pounds.
I see. So that clear a lot of stuff. Yeah.
Yeah. And so, I mean, admittedly, the guidelines are loose right now. And it's the same way here in the US and Europe as I assume it is in Thailand, is each mammographer is going to set the pressure based on how they've always done it, how they've been trained. But that's consistent from person to person. And like I said, the compression really, really changes the image quality in the image. And so if you're not consistent, especially from patient to patient, so you go from time 1 to second time or third or fourth time, if the compression's not right, you're asking the radiologist to have to look at the anatomy differently every time. And that's the idea of trying to be more consistent with the compression, because it makes the image quality more consistent over time.
I see. Yeah, that makes sense. So the key is compression. We need to get the right amount of compression to get a good image quality and consistent quality.
Yeah.
Yep. Okay. So let me see. Seems like we don't have any questions right now. Yep.
Okay.
Yes. So maybe next week that we are going to talk about the dose and also how to set up the dose alert level that may more like a more practical for us, and we can like concentrate on that part for the dose things.
Yeah, we're definitely going to talk about the dose metrics. Well, actually, there's only one, mean glandular dose. We'll talk about that. And then we'll talk about how to optimize that. And so, yeah. And just like we talked about at the beginning, if people in the audience have specific topics or questions they have, we have 2 more weeks.
We have 2 more weeks.
Yeah. We can focus part of next week on a topic. Or if you let me know soon. If not, or if not, we can definitely focus on maybe 2 specific topics in 2 weeks from now. So however you all want to do that.
So for the audience, if you have any like a specific questions or topic that you want Dr. Brady to talk about, so send me an email, or you can put on the Facebook on the link on the live that we have right now, so I can communicate with Sam so we can get that topic delivery to you in next 2 weeks before we finish this course. So I think we are done for today. So please complete the evaluation form by Thursday midnight. So Friday you will get a certification and also a link for next week, which we're going to talk about the dose for the mammogram and also how to set up the dose alert level. And yeah, I think that's it. So thank you so much, Sam, for giving us a talk today, and I will see you again next week. So have a good night, and thank you so much, everyone, for attending the lectures. สวัสดีค่ะ บ๊ายบาย